Life-saving cancer prevention starts with early detection and understanding your personal risks. Today, technology and medicine are merging in powerful ways. The Hennessy Institute offers an innovative health risk assessment to determine your potential cancer risk and help intercept it at an early stage. You complete a questionnaire about your personal and family history. One of our nurse navigators guides you through personalized strategies and next steps. You can meet with a genetic counselor and a cancer genetics clinician who can help you better understand your cancer risk and develop a personalized screening, early detection, and prevention plan. Even if you're not known to be high risk, you might be offered a molecular screening test using new technology that detects many cancer types by analyzing tiny changes of cancer DNA in your bloodstream, empowering you to act proactively. Together, we can intercept cancer before it develops. Take charge of your health today. Visit hackensackmeridianhealth.org/Hennessy Institute for our health risk assessment.
Ladies and gentlemen, welcome to the inaugural symposium hosted by the Hennessy Institute for Cancer Prevention and Applied Molecular Medicine. Before we begin, just a few housekeeping items. The bathrooms are located outside the left conference room doors. To get there, please make a right out of the doors and go right past the information desk. The bathrooms will be located on your left-hand side. Dinner will be served at 6 o'clock p.m. Please return promptly to your seat in the conference room and dine during the roundtable discussion that will take place. In order to receive CME credit, please make sure you are registered for this event. At this time, please welcome Dr. Obeid to the podium.
Well, I made it. I had a back problem, but I'm here. So thank you guys for being here. It's really my great honor to welcome you all to the inaugural symposium of the Hennessy Institute for Cancer Prevention and Applied Molecular Medicine. Today marks not just a milestone, but actually a mission in motion. That's how we see it. It's a mission to reimagine what is possible in cancer prevention and cancer care by shifting the focus from just treatment to catching cancer early and knowing who's at risk and how to intercept cancer before even can take charge. So I'll admit it was hard to get here today because of my back, but I'm so happy, and I thought nothing would make me not be here for this very important event. And this vision, just want to say, it would not have been possible without the generosity of the Hennessy family. And thank you, Shannon, for being here and representing the family. Their belief in cancer prevention is really what got us to where we are here for the Institute. And it's because of their generosity and their support for this mission that we have been able to screen and give care in just a matter of 9 months to over 2,400 individuals who came to the Institute. And just to let you know, the Institute, we just launched in August of 2024. So this is very new, and yet our presence is already big in New Jersey. And of course, I want to thank Dr. Gua for believing in us and our team and for putting us in charge of getting this to happen. So HiCap exists, so the Hennessy Institute exists and at the intersection of science, clinical care, and of course, public impact. We want to make sure that we reach everyone and people in their communities. Our goal is clear. It's to identify cancer before it starts or before it spreads through advanced genetics, early detection technologies, and outreach that reaches every community. And finally, I'm deeply grateful to our keynote and panel speakers, Dr. Olopati, Dr. Hall, Dr. Weitzel, and Dr. Chung. They're all renowned national leaders whose pioneering work in cancer genetics and cancer prevention continues to shape the future of precision prevention and genomic medicine. And with this, thank you for being part of this day. I know the conversation is just starting, and let's begin. Thank you. So I would like to introduce our first speaker, Dr. Hall. Dr. Hall is a gastrointestinal oncologist, and he's a professor of medicine at Fox Chase Cancer Center. And he's the co-leader of the Cancer Prevention and Control Program at Fox Chase. He's trained in health services research, and he's a clinical cancer geneticist. His current research includes the study of patients' attitudes and preferences towards hereditary risk assessment, genetic testing, chemoprevention, and novel methods to communicate high risk for individuals and their families, and also collaborative research in gene discovery and large testing databases with a focus on cancer disparities. Dr. Hall and I worked for 10 years, and I'm very happy that he was able to join us today. Thank you.
All right, raise this up. Thanks very much. I'm glad to see such a great big crowd, and this is an area that's very exciting and dear to my heart. And I haven't been up to this center for probably 10 years, since a dear friend in New York developed leukemia. I was telling the group I was talking to earlier, and came here, and you guys cured him. So I have there's a place in my heart for this center. So thank you very much for the kind invitation. And I'd really just like to thank Dr. Abid. I'm very, proud of him for his accomplishments and being here and leading this group. So I hope you'll find the next 30 minutes interesting. So actually, how do I advance this? I'm advancing on, I need to go back now. All right, okay. Just have a brief overview of what I'm going to talk about. All right, we'll start over again. So I told Dr. Olapati she might not like my first slide, because I was thinking about where has sort of the history of prevention, so what have been the eras of genetics and prevention? So we had this initial era in the 1990s up to the early 2000s, where it was all about cloning, it was all about finding genes, it was all about linkage. And that kind of led us into what I sort of thought of as this golden era of preventive trials. And if you think about between the early 2000s and really into 2010, all of these really fantastic trials, STAR trial, finasteride, polyp prevention, all of these things were run and reporting out during that time. And those are still today the fundamental trials that are guiding what we're doing in prevention. Unfortunately, or maybe fortunately, towards 2010 into 2012-15, genetics and genomics took over. Suddenly we had next-gen sequencing, and we got all into the big genome, whole genome sequencing, and it's sort of taken our attention a little bit away from the traditional prevention trials. And I think one thing that I think we're gonna all discuss here today is how do we keep attention on prevention, but build it into the things that we're doing now, which is big genome, AI. How do we do all of those at the same time, and not lose some of that momentum we had in the early 2000s, which is really, again, still define the things we do today in prevention. So it's remarkable then to me that really during that period of time, and the things I highlighted in red were all things that came out of that era, that now we actually have at least some area or some tool of prevention across almost every area of cancer. But I think anyone in this room would argue that we certainly need more. We need more tools to help as we've gotten more sophisticated about disease. So when I was thinking about, what are, really kind of the building blocks of prevention? What are the ways that we can go about preventing cancer in the population? These are the ones I came up with. I'm not going to run through all of these, but I was thinking, especially Dr. Obeid used the term interception, and I think this has become, I'm going to comment on that in a minute, sort of a more popular word. But I was sort of thinking about what is prevention and what is interception. So again, I came up with these building blocks of all the different ways I think right now in cancer care and in public health we have to prevent cancer. And I'll talk a little bit about sort of where we're moving in new directions relative to these. One question that comes up a lot, or that's been brought up to me is, what is interception? I feel like we used to always call this cancer prevention, and now everyone's saying interception, and I don't understand the difference. So I'm going to comment a little bit on the difference in a minute. There's all these new technologies coming along, and I'm really going to focus most of my talk here on some of the new technologies in GI prevention, because I think that's where my expertise is, and that's where I can add the most and sort of teach you what's new in this area. I'm going to just add a little bit along the way about patient preference. I think this is an area that my group researches a lot, and I think when we're thinking about prevention, one thing we really have to be focused on is how are we going to maintain adherence? How are we going to focus on patient prevention? It makes no sense to spend millions of dollars creating interventions that people don't use, right? It's a total waste of our money and our time. So that's one thing that my group's been very focused on, is trying to understand what is it people will actually use, so then when we go out and develop interventions, they'll actually be successful. So if anyone who knows me will find this slide a total joke, because no one knows less about football than the guy standing in front of you. But I thought for a Northern Jersey crowd, pictures of the Eagles might get you revved up a little bit. So prevention, versus interception. What's the difference? So I think of prevention, and I researched the literature and what people are saying a little bit about this is more really sort of dealing with or addressing the risk factors, trying to reduce exposures that we think ultimately go on to cause cancer, doing preventive surgeries that remove at-risk organs before cancer develops. Whereas interception, so prevention I think of as actually early. Prevention is actually applicable to the whole community, to everyone in society. And prevention in many ways is about behavioral change and is actually very inexpensive. You just have to really get it on people's radar. Interception, this newer term, I think is much more about detecting some of the very earliest transformations of cells into cancer and using newer technologies to address those, whether it be vaccination, some prophylactic surgeries. I think you could argue like a colectomy where someone has multiple polyps, some screening, and then of course some of the newer molecular detection assays that are coming about from various companies. I think these are going to all be really important in this place. So when I grouped those different building blocks, I think still a lot of the things we're doing still are falling on the prevention side, and I think still are incredibly valuable. And like I said, fairly inexpensive and approachable to the community. We just have to get the word out. Interception is a growing area, and I'm going to talk again, focus a little bit on vaccine prevention and Lynch syndrome, vaccine interception and Lynch syndrome, and give you a flavor of sort of how that works. So for the talk, I thought I would really focus on some of the innovations, particularly in colorectal cancer prevention, both for the average risk population, for Lynch syndrome, and if I have time at the end, I'll talk a little bit about FAP, and I'm going to just try to keep track. Dr. Obeid, if you can wave at me when I'm getting towards the end, that'll help me. There's no timer here. So in colon cancer prevention, I thought what I really wanted to highlight to folks here, if they were not aware of this, is that just sort of back to that first slide I had with all the sort of colorful changes and how the genome has really become our obsession, much more so than prevention trials. One place that high-powered genomics is really helping screen the population is in colorectal cancer screening. And we've had a number of big studies that have looked at novel ways of both stool-based screening and blood-based screening to screen for colorectal cancer. cancer. And while these are not perfect technologies yet, I think they are really going to reshape how we're able to screen the population, because they are much more approachable to the population, and they are going to be much better at encouraging adherence. So one of the first trials that I think has been really big in the last few years was the Blue Sea trial. So this looked at a stool-based, multi-targeted genomic test to look for cancer. And what this study showed, I have to say these numbers end up being very small up here, but the sensitivity overall of this test was quite high. It was over 90%, 94%. And one thing that was quite impressive as well, as you'll see compared to the blood-based DNA test, was that the sensitivity for advanced neoplasia was also quite high, was in the 40% range. Which you'll see on the DNA test was not quite so high. So these tests are better, of course, at detecting cancer than they are at detecting precancer. But nonetheless, 90% is not bad. And especially when you have a population or people who may choose to not do any screening at all. The specificity also, which I think is a really important thing to come out of this, is quite high, meaning with a negative test here, you have a pretty good sense that this person probably doesn't have cancer. And I think that is a huge advantage. The Eclipse trial, which was just reported just this past year by Dan Chung and a bunch of other colleagues, used a DNA-based blood test. And I think this is, of course, even more practical, right? I mean, as much as the amazingness of the numbers from the stool-based test, it's still stool, and that's a challenge for patients to have to do a test that involves their poop. So a blood-based test is something they can get every year when they go to their doctor, and so that makes this much more approachable. Sensitivity, not quite as good, particularly for those advanced lesions, but the specificity, again, still very high. And I think that's a huge value of this kind of testing moving forward. Finally, there was just, again, another recent study called Preempt, which rather than DNA-based, it was looking at RNA-based. And you'll see that the numbers are not quite as, the sensitivity was not quite as good, but again, still a very good specificity on a test like this. Whether RNA or DNA is really superior in this kind of screening or not, I think is probably just really a question of economics. But I think overall, this is a very encouraging space. And the reason I think it's encouraging is because of this slide I borrowed from Dan Chung via Bill Grady, who was giving a talk at Fox Chase and showed it, is thinking about these tests again, kind of back to what my group is interested in from the preference standpoint and the adherence standpoint. The sensitivity of a blood-based DNA test for colon cancer may not be, as high as that colonoscopy, but when you think about how many people you're going to be able to actually deploy the test in and get a result to determine whether they have cancer, when you factor that into it, as Dan called it here, the effective sensitivity of that test is quite high. And so I think that's where the advantage of these tests is going to be. The other thing we're seeing is that when we moved the age of colorectal cancer screening down, the GI docs are overwhelmed right now with business. There just are not enough docs out there to do it. So what's new in Lynch syndrome? Just for anyone in the room who's not obsessed with Lynch syndrome as I am, this is a very common cancer syndrome, one of the most common out there that we see in the clinic, 1 in every 300 Americans. I always tell people 1 in every 300 Americans is a lawyer. So if you know a lawyer, you probably think about all the lawyers you know. That's the number of people who have Lynch syndrome, but probably just have no idea that they have it. This is, a disease that really has come a long way in recent years. Many more people are aware. We have many more things we can do for these patients. So one thing I wanted to point out was there is a really powerful aspirin story in Lynch syndrome, which, aspirin goes through waves in medicine. There's sometimes where it's really popular and everyone wants you to take aspirin. Then studies come out like the Esprit study and everyone's like, aspirin is terrible, don't take it. But in Lynch syndrome, aspirin has a very important preventive benefit. It can reduce colorectal cancer incidence by 40%. John Byrne, who's shown here, did a lot of that great work, and there is another trial that has looked at multiple dose levels of aspirin, so hopefully we can use a dose as low as 81 milligrams. He actually gave a talk up at Dana-Farber just a few weeks ago and gave a teaser that when the data come out from this study, that it looks like there was as much effect at the 81 milligram level as at the 600 milligram level, so that'll be very exciting when those data come out. The big issue that we have with aspirin is, again, a study that I did with one of my fellows, shown here, is that unfortunately people don't take it. We looked at our Fox Chase population, then we did a more national-based survey, a convenience sample. We found that actually only about 25% of Lynch syndrome patients were actually taking aspirin specifically for prevention. If you looked at those who also took it because they had heart disease or something, you got up to maybe 35%. But that's 65% of people who could benefit from risk reduction who aren't doing it. And when we probed the reasons for this, it wasn't because they were afraid of side effects, and it wasn't convenience. They think taking aspirin is a lot easier than doing a colonoscopy. It's that they don't believe in it. They don't believe that it actually has the ability to do the same benefit for them or close to the same benefit as getting a colonoscopy. So that's a knowledge gap, right? And we just need to educate people that this is something that could really help them. And I want to just give a shout out to my fellow Sachi Singhal, who helped me write that paper. Just one thing a lot of folks don't know is also within the CAP2 study was another randomization looking at resistant starch. Resistant starch, for many who don't know, is many of these cornucopia of foods, including bananas and pastas and some other things. But what this study, one reason why a lot of these data haven't really been well accepted is because they actually saw, rather than a colon cancer reduction from the starch, they saw a reduction of all the other Lynch syndrome cancers, not colon cancer, which is a little bit of a head scratcher because they were expecting the impact to be on colon cancer. So I'll say that this is still a bit of a question mark in the field. It was also a little bit challenging because the amounts of resistant starch that apparently you had to consume to get the benefit was pretty high. But I did find out recently from someone that you can just buy a bag of resistant starch at Whole Foods. I should not have said that. I'm not advertising for Whole Foods. But anyway, depending, you can either eat something like 15 bananas or a couple tablespoons of resistant starch from the bag. We're also actually doing a pretty cool study at Fox Chase that's going to be finishing pretty soon, combining atorvastatin with aspirin. My collaborator, Margie Clapper, started this in a mouse model, and we moved it into our Lynch syndrome patients. We just accrued actually our 50th patient, which we'll finish the study off a few weeks ago. So this will be exciting. We found in preclinical models that atorvastatin, particularly in the pre-polyp, pre-cancer state in the mice, was suppressive of developing polyps and cancer. So we enrolled two groups of Lynch syndrome patients, some who had neoplasia before, some who hadn't. And I'll be excited to hopefully present these data maybe at the next iteration of this conference when they're done. One question that we get a lot is, these immunotherapies that I think, everyone has heard about at this point, nivolumab, pembrolizumab, all these things that are really changing the face of cancer, can't we just use those as preventive agents? Folks have tried. There was actually a study early on engineered by Joanne Jeter, who's now at City of Hope, which unfortunately the company that was supporting it pulled out funding, so it never got finished, looking at colon polyp prevention. So we don't really have any sort of prevention studies right now, but we do have this really intriguing paper that came out of Memorial just this past year from Emily Harold and Sophia Stadler's group. And what they looked at were a bunch of patients who were already on immunotherapy because they had cancer, and then looked at rates of developing second primaries compared to people who weren't on immunotherapy. And just to get to the punchline, what they found was For folks who were on that immunotherapy, there was actually no change in the rates of colon polyps they were developing, whether they were MMR positive or not, what we would expect in Lynch syndrome, or the numbers of polyps. That's the green box on the left. What was different was they were developing fewer visceral tumors, the kind of cancers that you would, like Lynch syndrome-related cancers of the uterus or the ovaries or the urothelial cancer. So they were developing fewer of those cancers while they were on immunotherapy, suggesting sort of a secondary benefit effect of being on immunotherapy. However, in the pink box, there were some other things that were sort of surprising and maybe negative. One thing is people developed many more skin tumors, even folks who had never had manifestations of Lynch syndrome skin changes like sebaceous cancers or keratoacanthomas. The rate in people who were on immunotherapy was 4 times as high as people who hadn't been exposed to immunotherapy. So now this actually changed practice. When we have patients on immunotherapy who we've, knock on wood, cured people, we've cured quite a few people now with immunotherapy, we immediately send them to the dermatologist because we know that immunotherapy can somehow bring out this risk of developing sebaceous cancer. So I thought that was really interesting. They also found that cancers that developed when patients were on immunotherapy were kind of younger looking as a cancer. They had fewer frameshift mutations. They had lower amounts of infiltrates of these kind of necessary immune cells. So the immunotherapy certainly changed the character of the cancers. One thing that I've been very fortunate to be involved in over the last few years has been the evolution of vaccines in Lynch syndrome. There have been several vaccines now that have been developed to help Lynch syndrome patients. The first one came out of a Swiss company that was a vaccine they had actually developed several years ago with multiple, actually 209. The reason it's called News 209, it was a 209 frameshift peptides that they basically packaged into this vaccinia virus. So they had first tried this vaccine in the cancer setting, found some benefit when pairing it with immunotherapy, but then, Eduardo Villar and others who are interested in this space took this to them and said, we should be doing a prevention trial. Patients with Lynch syndrome develop frameshift peptides very, very early on in the formation of disease. So this is really an interception type of situation because the frameshift peptide emergence is really a sign of a cancer forming. So we should use this frameshift peptide vaccine. And what they found was they basically got the company to buy in, and we did a trial of 45 patients at 4 centers around the country. Interest was through the roof in terms of people. I had people writing to me from Netherlands, from all over the world who wanted to come and get this vaccine. So the interest level was incredibly high, and we were able to show so far, the paper has not come out yet, that it really stimulated the immune system quite effectively. A group in Heidelberg is also developing a very similar vaccine. Theirs, it just does, instead of having 209 antigens, they have focused in on 4 very antigenic antigens, but similar idea. Their data have showed that the vaccine is effective, stimulates an immune response. These are data from mice. But they also showed that when you pair the vaccine with aspirin, you actually attenuate, or you actually augment the effect, whether you pair it with aspirin or with naproxen. So I think that was also a very important finding. So I kind of refer to that as the Heidelberg vaccine. They've also moved that into human studies. And then there was actually one other group out there from the Netherlands that was doing a dendritic cell vaccine several years ago. I looked very hard in the literature to find whether this had progressed, and it doesn't. It looks like the group got interested in dendritic vaccines and other things, so it doesn't look like they pushed that research forward. So it looks like it's really just these other vaccines right now. There is one other national study going on right now. This is the other funny slide in here. I do not have a lab. I don't have test tubes. But this was, of course, an ad that my center put together to make me look, important. But anyway, I am participating in this study, enrolling patients, and this is a vaccine that combines 3 different vaccines towards early colorectal targets. We're enrolling for this study 150 Lynch syndrome patients nationwide. It's open at 17 centers. Again, Interest has been gangbusters. It's been just bananas. We opened the study. We had like 12 patients on the study within 6 weeks. It accrued so quickly, the NCI actually had to cap accrual just a few weeks ago, which was 2 or 3 months earlier than they thought they would, which, as anyone who does clinical trials knows, very rarely happens. So we're very excited about that. One last plug I wanted to give in Lynch syndrome was, again, Eduardo Villar's group, a great group. They do a lot of great research, and they've actually also pushed into looking at physical activity as a means of prevention. And did this really nice study where they gave Lynch syndrome patients the choice. You can either go on an arm where we just sit you down and we do some education about exercise, or you can commit to doing biking 3 times a week. And I forget what the amount of time was, 45 minutes, 3 times a week. And then they looked at various molecular correlates in the colon. They looked at oxygen consumption and other things. And what they were able to show, first of all, patients stuck to the protocol. The red lines on the top are the people, the amount of exercise the exercises were doing versus the sedentary people on the bottom. So they were clearly very different. But what they showed was that the exercise, this activity had impact at the tissue level in the colon with changes in levels of prostaglandin E and other factors that we know are very relevant to cancer formation. So I think a really great proof of concept study, and it shows that, again, one thing, another education gap, we identify all these people who have genetic risks, but we have to communicate to them as well that there are things they can absolutely do about that risk, and exercise, eating healthy, some of the other things, in addition to the screening, can really help people. And I find that in my clinic, sometimes the things that people are most interested in are the things, what can I do myself to help, change my risk? Everyone, fine, getting a scope, getting a blood test, but what can I do? What can I eat that's going to help me? How can I exercise? Finally, just a few last words about FAP. FAP has suffered from a lot of hard hits in terms of studies that have failed, and this was unfortunately another study recently from Carol Burke. Not that we didn't learn a lot from the study, but it was hoping to pair eflornithine with sulindac as a way of lowering polyp count. The primary endpoints were not met. There were some secondary endpoints that were positive. The overall polyp burden seemed better, but again, still we don't really have a great preventive. Sulindac is sort of our aspirin-like prevention agent in FAP. There is another new study going on now called Tupelo, which is looking at a MEK inhibitor in this space. So this is accruing all around the country, so I think exciting. And if people have patients, should definitely refer them into this study. It takes a couple of years at least to get these studies accrued. The last paper that I thought was really exciting in the prevention space that I wanted to make sure everyone was aware of was this paper that appeared a couple years ago in the New England Journal, but it looked at gastric cancer risks in BRCA carriers. And this was from a group from Japan using a large database they had. But what they found was, to jump to the punchline, was that BRCA carriers who were H. pylori infected had a multiplicative interaction and risk of gastric cancer. And I think what's so important about that, again, is back to this idea that genetic risk is just one layer of risk in the population. There are these other things out there, like H. pylori. When I saw this paper and then I looked at H. pylori rates in Philadelphia, in some populations, like underserved Hispanic populations, African American populations, it's estimated to be as high as 35-40% of people are carriers. But yet we're not necessarily screening people to find out. And we have ways to treat this. We have antibiotics. And so I think this says that there's a burden to us to be aware of these things, to identify these risk factors so that we can reduce these risks and hopefully mitigate the risks that people have from some of these risk factors they've inherited, like BRCA and these other genes. With that, I'll end. Thank you again for the invitation.
Thank you. Great overview. What's the most believed mechanism of aspirin prevention in Lynch syndrome?
It's a good question, and I think that our belief is that it is to some degree, somehow an overactive immune response, perhaps, that ultimately leads. I don't have a great answer for it, but we think it's related to overactivity of the immune response and somehow aspirin being able to quiet that and allow more effective generation of a targeted immune response towards the cancer.
Can you comment on the role of microbiome and food in that context?
Yeah, so there's a whole nother world. Yeah, about.
We need another talk.
Yeah, no, but there's been some really interesting papers in this space. So both in the Lynch syndrome and FAP space, there have been some really great papers showing that there's clearly interaction between microbiome and hereditary risk. One great paper that came out a few years ago was from Cindy Sears' group at Johns Hopkins that showed that FAP mutation carriers who had overabundance of, and I'm not a microbiome guy, so I don't know all the different species, but who had an overabundance of certain species in the microbiome were much more likely to develop cancers than other carriers who didn't. So there was clearly this crosstalk between the microbiome and the hereditary risk. So it's definitely at all of our conferences, there's always like at least one microbiome speaker talking about moving this field forward.
The last important question is that there's obviously a huge increase of cancer, 80% in incidence in people less than 50,
yeah.
And GI cancers, advanced stage young patients in their 30s, right? They think the colonoscopy for the grandparents, not even the parents, and we know that a lot of it is lifestyle related. We don't have a clear answer yet, but I was wondering if you can comment on that in that setting.
Yeah, I mean, I think one thing I can say is I think I don't think it's necessarily genetics in the traditional sense that we think of it, right? Because I don't think we think the rates of Lynch syndrome or other things are changing. I think one clue we have is that we're seeing these changes worldwide and not just in the United States, right? So that has to be something that's changing, again, worldwide. So I think my belief is there has to be probably something related to how we potentially get energy and energy consumption. We're bigger people, we're better fed people. Our bodies mature faster, right? We see that young women, in this day and age, have their first menstruation many years earlier than they used to 50, 60 years ago. So I think that's part of it. I'm not sure we've figured out
to this point, the early data suggests that people can age biologically faster because of lifestyle-related conditions.
Yep.
Thank you.
Yeah, sure. My pleasure. All right, thank you very much.
Thank you, Dr. Hall, for this wonderful talk. And now it's my great pleasure and honor to introduce Dr. Olopade. She's our keynote speaker today. So just a little bit of background. So Dr. Olopade is the Walter L. Palmer Distinguished Service Professor of Medicine and the founding director of the Center for Clinical Cancer Genetics and Global Health at the University of Chicago Medicine. Dr. Olopade's research is focused on gaining a better understanding of the root causes of breast cancer in diverse populations. She's published extensively on genetics and non-genetic risk factors for breast cancer, and she is internationally renowned for her work in young-onset breast cancer and clinical expertise also in early detection and prevention of the disease. In her laboratory, Dr. Olopade maps genes frequently altered in cancer and has characterized the molecular pathways defining aggressive forms of breast cancer in women of African ancestry across the diaspora. She has been indicted into multiple of the national foundations, including the American Academy of Arts and Sciences, the National Academy of Medicine, to name just a couple. She's also a MacArthur Genius Fellow, and she's certainly an advocate that has been seen by us who trained with her. She's an advocate for patients, for social justice and equity. She has earned her medical degree from the University of Ibadan in Nigeria, and she did her training at Cook County for internal medicine, and then at the University of Chicago, where she has stayed till now. And she has graduated so many of us, including myself and Dr. Hall. Thank you so much for being with us today.
Yeah, it's really great to be here, Dr. Guy. Thank you for allowing my former trainee to come and start this institute. And I really must thank the Hennessy family for starting this institute. And of course, Dr. Weitzel is here, my co-conspirator in this idea around using genetics to change the world. So I want to thank all of you for spending your Wednesday evening with me. I started in London, and I'm really going to try very hard to not keep you here without dancing and entertaining you. So let's get going on this entertainment. So I've been fortunate to leave Nigeria and then land in Chicago. And I talk about Chicago being the flyover state, right? We're not on the East Coast, but what I loved about my ability to be in Chicago is a city of neighborhoods. You don't cross into anybody else's neighborhood. But we get lots of people who come to train with us. And as a result of that, I've been fortunate to have people like Michael Hall and amazing mentor. I want to thank the nurses that are here because this is Nurses Week, right? And sometimes we take their role in medicine for granted. My mentor, Dr. Rowley, when she went to medical school, was one of the very few women who were allowed in medical school. And if you remember, this week we got a new pope from Chicago. So I'm really very, very proud of my Chicago creds, right? Because Chicago were always experimenting and just moving the needle. So when I arrived, my section chief, Dr. Gollum, had really wanted to be a medical geneticist, and he would tell us about the stories of how they evaded the war in Vietnam and went to work at the National Institute of Health because they wanted to do genetics. And Dr. Vardaman, the hematopathologist, and every Friday morning, they made us as fellows go to look at what's going on in the bone marrow. And I was fascinated by that, and that's why the next generation that came to study in our fellowship program, like, Dennis Lehman, for those of you who do breast cancer research, you will understand that Dennis Lehman basically transformed the most lethal breast cancer to the most treatable breast cancer. And I was a fellow, and the day he came back and was telling us about this science paper and how he was going to find a cure for HER2-positive breast cancer, I was there. How could he be so sure? But guess what? He was done right. And the story of genetics and what we believed or what we didn't believe was actually what I thought I would share with all of you. Because at that time, we knew, once we looked into under the microscope, that there was risk-adapted treatment for every leukemia. There were some leukemias that we treated and we didn't need to have a bone marrow transplant for. And there were some that were lethal. There was nothing we did. So as a fellow, my job was to just look at the patterns, right? This was fascinating research where you could find a gene and then you can change the landscape of what was going on. So that's why some of us that then came after them then decided, okay, let's just keep finding genes and finding more and more genes. And so Dr. Hall, I know you were really making fun of us in the 90s, but the idea was we didn't have any effective treatment for solid tumors. We didn't have any, we were using nitrogen mustard and, the more chemo we gave, the more we thought we were doing better. Until Dennis Lehman said, no, more was not necessarily better. And now we're all talking about precision medicine. But this is really because research moved the needle. So write your Congress people today. We need more research, not less research, because our work is not done. And our work is not done because I'm now a chair of the American Cancer Society Roundtable. And for those of you who are not paying attention, the reason why we're worried about young people getting cancer is because when I started and I got drawn to go and do work in breast cancer, I remember I used to write my grant and say 178,000 women will be diagnosed with breast cancer. Guess what it was this year? 316,000. How is that possible within 20 years of really trying to do this work? So whatever it is that we're doing, we're not doing as well as we should be doing. And that's really because, number one, we're looking at age, and then we're looking at who dies from breast cancer. The good news is we're all living longer, right? Thank God women are not dying during childbirth. Women are not dying prematurely. Globally, there's still women who are dying during childbirth. So that's why my movement for women is about whether you're a man or a woman, you have somebody who birthed you, right? So that's why this work has to be done in solidarity. And it's not about red state and blue state. It's about all of us really focusing on women's health. Because if we focus on women's health, trust me, the guys will follow us. Okay? So why did we think age was the most important thing? Well, it's because when you look at under 40, who dies from invasive breast cancer? Only 2%. But guess what? Those 2% are somebody's mother who died prematurely. So we can't say because there are not too many people who die under the age of 40, we should all wait until we're 50 to start doing mammograms. That's been what the ACS was telling us for decades, okay? And the reason why we sort of got stuck with when you get older, go and get your mammogram was because, yes, we had to respond to the epidemic of breast cancer. We had to say, why are women dying? And women marched on Washington. And so we detected more and more breast cancer in white women. And now we're saying, well, maybe there's some cancers we don't even need to detect, right? Because we have overtreated a lot of women. And guess what? We haven't really made a big difference in mortality. The reason why we're talking about this new data in a serious manner is because we live on an island, right? Some of you came through Ellis Island, and some of us flew on planes, right? But we're all in America. And the thing is that if you see different people, you might not know who is in your community. And that's why I'm telling everybody, just go back to your community. One size doesn't fit all, right? So by sitting in my practice in Chicago, of course, most of our data has been white and black, but we all know that there's shades of gray, right? We all have mixed blood somewhere. But the reason why, even though our incidence rate is declining, mortality is increasing for some, is why we're all up in arms now to say, what's going on? Let's figure it out. And so the reason why the young onset, I'm giving you the data for breast cancer, but Dr. Hall just talked about colorectal cancer. What is going on where women, where you have this tick, right? What is going on when you look at women between the ages of 20 to 49 versus 50? So American Cancer Society, and if you follow guidelines, how many of you women here know when you should get a mammogram and what year you should start your mammogram, whether you should get it every year or you should get it every 2 years? We just don't know because we have so many different guidelines. And the idea is that if you start looking at the data by between 20 and 49, what's going on here, and then you ask everybody to wait until 50 before they get their mammogram, how many lives are we going to lose because we said one size fits all? So this is why we begin to really begin to say, what's going on here? Look at these Asian American Pacific Islanders, 2.6% increase. What happened to them, right? I remember at one point in my practice, everybody thought we should all start eating soy because breast cancer rates are low in Asian women. And so we did, the good old studies on prevention. Everybody was buying soy. But it's not about the soy. What is it about? And what should we be thinking about when we live in a diverse country as this? So this is really why we need to do better. So regional, getting people diagnosed regional is flat. Getting people on stage or at the stage of diagnosis, you can see local, where you already have lymph node involvement, is going up. And then no difference in women who suddenly show up and they have distant metastasis. So I don't know whether the rule in New Jersey talked about density. How many of you now talk about density to your patients? So now we have different people saying, well, what cancer is going high? Is it ER positive? Is it hormone receptor negative? You can see the hormone receptor negative is flat, right? Because of the way we're trying to develop, to identify cancers. And these cancers, you can still see that, whether it's white, black, Hispanic, it's the hormone receptor positive breast cancer that's going high. So when my patients come in and they said, black women die from triple negative breast cancer, I said, no, they die from hormone receptor positive breast cancer. I remember in 1992, when we started the first prevention study, 1992, I was on the front page of the Sun Times, and I got proposition from jail because this was this beautiful black woman, right? Asking people to participate in the prevention study. We thought once we got tamoxifen, we were using tamoxifen to treat breast cancer. It was the first medical alert that the NIH told us, look, give women tamoxifen. Young women who were given tamoxifen have a higher chance of surviving than if they didn't give tamoxifen. Guess what the guys who were medical oncologists at that time were doing? They were like, oh, no, women cannot take tamoxifen. Until the government said, give them tamoxifen. So now we know tamoxifen and so many other medications, including baby, there's so many drugs now that we can use to prevent breast cancer. So why aren't we using them? Well, women don't like menopause. And if you take tamoxifen, you're going to get into menopause. Well, the day I became menopausal, I was like, that's overrated. You just need to think somewhere differently. But there's a whole menopause movement now. How many of you have gone to see a menopause specialist? Okay, so I did a talk once with a menopause society, and I was like, okay, how many of you have done your risk assessment? Whatever you're going to do in your practice about menopause, first of all, make sure you do your risk assessment. Because what's happening is that there's a whole thing that we have learned about how to treat hormone receptor positive breast cancer. We have learned about what hormones do in women's body. And for a very long time in my clinic, when I tell women, okay, let's try to prevent breast cancer, the number one reason they don't want to take it is hot flashes. I'm going to be depressed. I'm going to be anxious. And I was like, well, I'm not sure if that's the reason. But we haven't studied it. We haven't paid enough attention to quality of life. This is why we're talking about what do women need and when do they need it, right? Those are important questions in women's health that we have not answered. But the thing is that if we look at what we have accomplished by getting women to get mammograms, we expected that there would be a continuous rise in breast cancer deaths until we thought we had won the Cold War and women marched on Washington. And because women marched on Washington, people like me who were not studying breast cancer went for the money. And the Department of Defense started funding women's research. The women advocates made a national action plan, and you can see how many deaths we averted. So the point is not that we haven't averted deaths. The question is, can we do better? And we can always do better, because when you work with breast cancer advocates, they'll tell you that until everybody has equal chance of surviving or preventing breast cancer, we haven't done enough. And so this is why we're now looking at the distribution at diagnosis, where we can't, say that, yes, we get this number of patients who are diagnosed, but all this who come in with regional and distant, and we have 44,000 women dying each year from breast cancer, that's a good outcome. So for those of you who are sitting down there and saying, well, let's worry about the young women, I want to use this example of my 68-year-old. I live in Hyde Park, and it's a place that is actually really very diverse. This woman did everything we asked her to do. She had her mammogram on March 6, 2003, and she came March 8, 2005, and this woman has very dense breasts, but even then, the cancer wasn't there. But this woman, from her screening mammogram to the time I saw her, looked like she had a lymphoma growing in her breast. And I was telling Dr. Guy that I used to be a lymphoma doctor. That's why when I started thinking about breast cancer heterogeneity, I'm asking myself, who gets this type of aggressive breast cancer? Do we know? So when you tell a woman to go and get mammograms every 2 years, and she does it, and still comes in, and within a year, she's dead from aggressive triple-negative breast cancer, do you think she's going to believe you the next time you tell her, oh, we've got something that works? So there are two things I do that nobody believes. I believe in genetics, and no, it's not genetics, it's the environment. And then I think vaccines actually work, because people like me would have died in childbirth or before the age of 5 if I hadn't gotten the measles vaccine and I hadn't really gotten all the immunizations. So during COVID, when I'm telling people in my neighborhood that, do you know that when we vaccinated people like me, I had a chance to live to be this ripe old age. So as we're all really benefiting from science, from technology, in my neighborhood on the south side of Chicago, people don't take the flu vaccine because they don't believe that if they get the flu vaccine, they're going to get sick, and they can't afford not to go to work. And I would tell them, it's a reaction. Once you get it, you're going to get better. But this is how the community distrusts us, when we don't explain to them what's going on. The good news is, so I did this study where we have I Spy, where before you even touch that breast cancer, you give chemotherapy. And this is the same thing that has happened in colorectal cancer. This was how we treated lymphoma for a very long time. We're not going around cutting lymphomas all over the body. We're giving effective therapies. And some of those treatments, chronic myelogenous leukemia, how many of you work in leukemia or in blood disorders? Myeloma, right? A lot of cancers that we didn't have cures for, they're all over the blood. But once you have the right treatment and you give it to the right patient at the right time, the tumors melt away. So that's why we then said, let's start not, when black patients come to my clinic, they said, oh, don't touch it, because if you just put a needle into that breast cancer and air gets into it, it's going to explode. Have you heard that before? Don't let air in. So you know what? I said, fine, let's not let air in. Let's just treat it. Right? You have to meet your patients where they are. So we started giving women, I wrote a letter to the editor of JCO. I said, don't let air in. Let's give these women neoadjuvant therapy. And they won't publish it because they wanted data. Okay, now we have the data that if you don't let air in and you give everybody what they need, whether it's immunotherapy, whether it's HER2 targeted therapy, if they achieve a path CR, they do well. The cancer doesn't come back. So that's where we are with using molecular diagnostics. That's where we are with precision medicine. We can pick the cancer, we can diagnose it, and then if they don't get a PCR, then we can start looking at what's going on. Why didn't they get a PCR? What else should we be doing? This is really where we did two studies. One was with our data in Chicago, the Chicago multi-ethnic cohort, and everybody in Chicago comes from their parishes. So I have all the Irish Catholics, I have the Italian Catholics, all of them. You know where they are coming from by their name and their zip code, right? If you then go to a national study, which is the I-SPY, which is the investigators of serial, molecular biopsy, which is a national study, the same thing. They have a PCR, there's no difference between black and white because you are using molecular diagnosis to get them. So this is really why I think for us, we have to begin to think about all of us and the human race. We're one human race. Whether you believe in science or not, we all came out of Africa, right? And out of Africa, you now have these branches, right? The European branch, the Asian branch. But for us to get to the root of all what we're doing, we have to embrace our humanity. And we have to look at what is genetics, which is what I'm interested in and why I teach my fellows, understand genetics. And then when you understand the genetics, you can then layer the environment and all the other things, all the cultural things into it. So when we do that, then everybody is now really thinking about what do we need and how do we get the data. When you do genetic testing now, people are going to be talking to you about what they have learned. So there's what is called the UK Biobank. They wanted 500,000 individuals. But if you look at the biobank in UK, it's all about who came to England, where did they settle? They're all tribes too, within even that small island called the United Kingdom. The Scots hate the Irish. The Irish hate English, right? It's all about who won the last soccer match between, right? Real Madrid or Liverpool. They kill each other just for that. So that's human nature. But what we need to do is to begin to think about how we can do all of us. So in the US, we did the All of Us study where we're asking, let's look at the genes that are high risk and then the ones that we can actually look at. It's very common. We all share them. But we can add all of these things together and begin to look at who is at high risk and who is not. So this is where this year we're celebrating 20 years of BRCA2. How many of you have heard of BRCA2 mutations? Okay. How many know about BRCA1? Okay, so 1994 BRCA1, 95 BRCA2, and it turns out they may have the same BRCA in their names, but they're totally different genes. And now, every time I look around, somebody has found a tumor testing, identifies germline mutation in a 55-year-old dying of advanced prostate cancer. And I'm asking myself, why, after all these years, when we knew about these genes in 1994 and 1995, are my genetic counselors now finding this man? Because if you only blame the mother, and you ask, did your mother have breast cancer? Of course, this man's mother didn't have breast cancer. The father had prostate cancer, but he was older. It wasn't until you go to the previous great-great-grandmother that you would say maybe the great-grandmother had something. And who knows about what their great-grandmother died from in the old country. So that's why I've been saying, why just not test everybody? Who are we missing? So all of a sudden, now that we have drugs that men can use for treating advanced prostate cancer, all my colleagues want to test everybody. And now these are the kinds of people we're finding in our clinic. That is a failure of prevention, right? Because this man now has 2 sons, but then look at the relatives. And now we have to go back. So that's why tumor testing is going to find all sorts of things. And this is another favorite fan of mine who was in clinic with the same a fellow of mine, Stacy Gray. She wanted to do lung cancer research and to communicate. And she was the one who was telling us we need to do direct-to-consumer marketing. She said, why don't you just let everybody know about their risk? So at the time when people were debating, should we go and put ads in playbills in New York so that all the Jewish women could know about their risk for ovarian cancer? You remember Gilda Radner? I would not have had great Saturday nights without Gilda, right? Because I could just not go out and just party in my house with Gilda Radner until she died of ovarian cancer. So she was the one that really motivated us to say, we have to find everyone at risk of dying of ovarian cancer. And so she did this study, which I absolutely love, where they just got everybody, 29,000 patients at City of Hope. If you have money, you can do that kind of work, right? And she wanted to just look at how many of them have somatic whole exome sequencing, and then 23,000 germline. Because one of the things we focused on in our training program is your germline actually determines your somatic. Why are we now only just doing somatic panels so we can have druggable targets? So really proud of her. Because when they did that, what they're going to see is that if you just test everybody, whether it's at Memorial or it's at City of Hope, you're going to find a lot of people, and of course, the patients with breast cancer are the ones who are sort of jumping out there because they were the first adopters. I remember I would talk to women dying of ovarian cancer, young women dying of breast cancer, and they would tell me, I don't want this for my children. Please do this research. They gave us permission to do the research. They gave us consent to do the research. We passed HIPAA privacy laws. We told everyone, we can prevent these cancers. But guess what? When they start testing people, look at all the people who are being tested across a broad range of diseases, and look at the genes they're finding. BRCA1-2, PALB2. If just these three genes alone, they're the most actionable, okay? And then you have my favorite gene, P16 for myeloma, and then your Lynch genes. And what geneticists will say is if there's a test that you can find in 1 in 100 people that you test, that's a great test. This was the experiment I wanted to do in 1996, and nobody believed me. They were like, forget it. We're not ready for it. So are we ready for it now to actually find these patients before they come into our cancer center? This is why I'm really excited that we can begin to integrate somatic mutation. Everybody's getting tested. They want these drugs. And now we have mutational signature. This is really how do we integrate somatic mutational signatures in clinical practice to improve clinical outcomes? This is what I do in my lab now. Because when you go to the clinic and you see who is dying, the unanswered questions, then I have to go back and study. So unlike Michael Hall, I still do pipettes, and I'm in the lab, right? Because what we have learned is that mutational signatures from DNA repair deficiency in cancer have therapeutic implications. If you have this germline mutation, you are born with it, and you live all these years exposed to so many things until you come to this point where you are now dying of breast cancer, colon cancer, lymphoma, myeloma, and that's when we see them in our cancer centers. We must do better. So this is where the interception, the prevention comes in. And I'm so thrilled that you guys are going to do that, because one of the other big experiments that the US did was to start these US cancer family registries, cancer susceptibility across life course. And what they found is the same genes that are in the germline, their burden across the lifespan, and then somatic mutational burden across lifespan, they overlap, right? I know everybody wants to do a test now for longevity. They want to know their telomere. That's okay. But please, let's find those people who are going to die prematurely from early onset breast cancer. So that's why we've really been working hard to find the SNPs. This is whole genome sequencing. We didn't even stop just looking at our patients on the south side of Chicago. We're doing work in Nigeria, and we're defining how you can actually find these mutational signatures. So all you need to do is find the mutational signature. If you find this signature, you can find the right drug for the right patient. It doesn't matter where they come from. What matters is that many of these patients have not been studied. Many of them do not have access to our cancer centers because they're not where they can access it. So that's why, for us, the question, should every patient with breast cancer discuss genetic testing with their doctors? Yes, when they come to our cancer center, every cancer patient, all of you nurses, at the bedside, you get the family history, every cancer patient, because it can influence their treatment decisions. We may decide on surveillance and secondary prevention. Why are people learning that they have BRCA2 after they get ovarian cancer and they were surviving breast cancer for 30 years? That's failure of prevention. So you can either do primary prevention, but once you identify those individuals, you better bring their family members in because we have work for them. And that's why, after many years of being a medical oncologist, I changed my practice to preventive oncology. And now I hang around computer scientists. This is my radiology colleague. This woman, I treated her at, she had just gotten married, got her PhD, 29, developed breast cancer. And she's living with metastatic breast cancer. And she said, I don't have time, but you need to get data because I'm a physicist. I get data. I got my degree in physics, and you in biology are just taking one patient at a time. So she convinced me to join the AI revolution. And since we are now all in awe of Doge, I'm going to talk about why we shouldn't be in awe. Because she then paired up with another postdoc and said, you have been collecting all this information. You have the mammogram, you have everything on your patients on the south side of Chicago. Let's build a mammogram-based deep learning model for predicting breast cancer risk. And we want to be able to get the mammogram and then do 5-year risk score. And they've published this. It was amazing how well their model did. It didn't have anything to do with density. It had to do with what's going on in the breast, right? What are those early things that we need to really find? And if we find them, can we intercept them? So it didn't matter whether you were black or white. And we had an AUC of 0.7, which was better. And it was actually better in predicting 5-year risk. So what I want is every woman get your mammogram. Let AI tell me if you're going to get breast cancer in the next 5 years. If I knew you were going to get breast cancer in the next 5 years, what would I do? If you knew you were going to get breast cancer in the next 5 years, what would you do? Would you take a pill for prevention? Would you try to intercept it? That's what I mean by interception. And now we actually now have, so this is a patient that we're now really looking at how to use ultra-fast MRI, deep, cheaper, faster, and more accurate than conventional MRI or mammogram. We can see this even before the cancer starts. The question is, what are we going to do about it? Let me end by talking about the Lancet Breast Cancer Commission. I love going to the UK. So we all got together in Cambridge. And every time they spoke Queen's English, I said, no, we don't speak Queen's English in Chicago. We just want to be real. And what we wanted to be real with the Lancet Commission is, what are the magic ingredients for a Lancet Commission? Well, commissioners need scientific and activist genes. All my former fellows have activist genes because I birthed them. And all of you now from this talk are going to all be activists in your own community. We need to present a disruptive idea that may make uncomfortable reading, put the patient in the center, go beyond the biomedical, aim for a realistic utopia. So this is from the Richard Houghton, the editor. The utopia we're looking for is that we're all in this together, right? We have prevention, policy, and systematic risk assessment, everybody in this health system should have access to it. Personalized treatment with digital health as an equity equalizer. Metastatic breast cancer placed at the center of the report. Do you know that once you have metastatic breast cancer, nobody even knows that you are alive or not because it's not in the databases. And now my 22-year-old HER2 patient, positive patient, is surviving because she was able to access clinical trials. And all my fellows met this lady when she left her community and came to get that biopsy at the University of Chicago because she was an early adopter. So global early detection with coordinated health system, identifying and measuring the hidden costs of breast cancer, placing patients at the center of clinical communication. And if we're going to place patients at the center, nurses have to be there. So the American Cancer Society strategic priority areas, risk assessment screening, risk reduction, and early diagnosis. We moved away from early detections. You've got to figure out how to do that molecular diagnosis immediately. Because this patient it can be a difference between life and death. And don't open it until you treat it. Right? Give them access to clinical trials, access to treatment, and then, of course, support and wellness. And I'm so proud that you have an institute that is committed to, one size fits all was what we did in the past, right? Everybody waits until they're older, and then they think about screening. We have to go beyond that. You have to think about precision prevention and early diagnosis. We didn't say early detection. We said early diagnosis. On the south side of Chicago, women will have, mobile mammography, and then they will tell them to go and find a doctor to diagnose their cancer. Of course, there are no doctors on the south side of Chicago. How are they going to diagnose their breast cancer? By the time they show up to us, of course it's advanced. Of course, they have no chance of surviving. Is that because they're black and fat, or is it because they have no doctors? So let's think systemically about it. So for a long time, we blamed the victim because we didn't create the system to catch them. So now I'm glad that we have a lot of things that we can do to personalize prevention. I'm so proud of our fellows and former fellows who are really moving this because we can do all of this. Low dose lung CT. We can't wait for advance. Many more women are surviving lung cancers now. Men are surviving lung cancer. Asian women, that is what they care about, that they get screened for adenocarcinoma, nutrition counseling. So those are all things that I think we can do if we embrace science and technology. It will improve outcomes for all cancer patients across the continuum of care. And I think I will really end by thanking everyone who's contributed to my thinking about this, because this woman is a BRCA1 black woman who also have, colon cancer in her family. And she's had breast cancer 3 times. But she keeps telling us why we must do research, how to consent the patient. And of course, this is Shirley Mertz. She went to the White House and said October 13th. How many of you know what we celebrate on October 13th? Metastatic Breast Cancer Awareness Day. So please celebrate on October 13th, because it's not all about go and get your mammogram. It's about getting this woman to survive 20 years. Now she may die of old age, 78, and she came to the theater with me at Easter, right? Her main plea when she first came was, I'm 50 years old when I had DCIS, was what she started off with. And then it recurred. But it was HER2 positive, and she's been on Herceptin and just been treated continuously to watch her children grow up and for her to now die of old age. So it's not that we're not going to die, it's that we're all going to have to think about how we live our lives meaningfully and joyfully. Thank you. Wow. That's what he asked me to talk about.
Wonderful talk. Thank you so much. I have a question. And you already touched base on the testing everybody. Everybody needs to have a chance. And I think for those who are getting to know the Hennessy Institute, we're telling everyone who wants to do the test, they can do the test. Now, if the insurance does not cover, there are resources. People may pay out of pocket for that. But I think you are a proponent, it seems, that, people who want to be tested, they probably should get the testing.
Yeah. So one of the things that I didn't talk about are some of the clinical trials that we have engaged in. And for those of you who have not heard about the Wisdom study, Women Informed to Screen Based on Measures of Risk. We started this study because I asked myself, what's my risk for breast cancer? When should I screen and how should I screen? And I've been talking about this all the time. And so, wisdomstudy.org, write it down. Wisdomstudy.org, I was on the advisory committee, and my friend Laura Esserman, who I met in 1996, she's a surgeon, and a surgeon at UCSF. Do you know where the highest rate of breast cancer is in America? Marin County. And then, of course, there's also the Long Island study. What is unique about Marin County? Do you know? Well, fabulous, rich, sophisticated early adopters of technology, right? So they, of course, get mammograms. They get everything that is possible, and we overdiagnose DCIS. That was our concern, her concern was that her practice was full of women coming in with DCIS that didn't even need to be treated. But because you go and get that mammogram, you get a biopsy, it just went sky high. And then we started learning about mama print, oncoprint. And then we realized, my good friend Laura Van Veer in Amsterdam, she did the best experiment that I think anyone could do. We were both working on BRCA1. And we found that there were women who had 5 centimeter cancers, 5 centimeter, big cancers. And they lived. They didn't even get any chemotherapy. Because in Europe and in the UK, everybody gets what they needed because there's a health system. But you know what? We learned something because those women participated in research. And we realized it wasn't about the screening and the first mammography studies were done in Malmö County, Sweden. How many of you are from Malmö County, Sweden? Or have relatives from Malmö County? But that was how we built our mammography screening. Blue-eyed, blonde, sweets. Then we tried to bring it to America, where we are a melting pot. And as a result of that, all our data don't fit, right? Because we don't know who is going to get that aggressive breast cancer. But the data that we were collecting was all about black and white. So right now, we don't know who is going to get aggressive breast cancer. The Wisdom study, we're going to recruit 100,000 women because we have found in I-SPY that was treating locally advanced and any tumor that was more than 2 centimeters. We find that we can, if you get a PCR, you're homegrown, you are fine. We know immunotherapy works, even for breast cancer. We're just giving immunotherapy to everyone with triple-negative breast cancer. Why does it work? How does it work? We don't know. So this is why your Institute of Applied Molecular Diagnostics will be important to the community and why everyone in the community must gain access. So what I didn't say now is that all the studies that we're doing now have liquid biopsy involved in them. Why do they have to come to my pathology department to know that they have HER2 positive breast cancer when they can just get a blood drawn at home? So they can get a blood drawn at home. If they have HER2 positive breast cancer, then let them get treated at home. If they have DNA repair pathway deficiency, well, it's an oral medication. It's a sub-acute medication. Those are the kinds of disruptive technologies that we are even imagining that Amazon will deliver. Can you imagine? We have drones at every wedding. Why can't we have drones deliver drugs to patients? Right? So if you imagine it, you're going to get there. So right now, we're doing the study of ultra-fast and abbreviated MRI. MRI costs $7,000. Our protocol will be $295. It would be even less expensive than a mammogram that will overdiagnose you and you then have to do biopsy. That's the future, right? And we can get to that future when we support research, and we're doing this in solidarity. So it's not about the interception or the prevention. I want to bring back everything that we did in the 90s, right? Before retirement, and let these guys do the studies. So that's why we need everybody telling people in their communities, have you done your wisdomstudy.org? We lowered it. In California, they had 48 black women. And I was like, bring it to my neighborhood, because my community supports me. And guess what? We have 4,300 women on that study. 25% of them are black women. Because when I tell them, that's what they're getting on the north side of Chicago, they're like, sign me up. They don't want to be treated differently. They want to be treated like everybody else. So the studies that we have done at our elite academic center is, if you ask people, they're going to say, I want to be part of it. The challenge we have is we're not asking people. So yes, my answer is, I hope you will use this money wisely, and you will let everybody go back and talk to their neighbors, and you can, disseminate this information.
I don't follow breast cancer literature, but years ago, there were some papers looking at detectable autoantibodies early on in breast cancer, because it's difficult to really go necessarily after liquid biopsies, finding the right genes, very early stage and all that, and sensitivity. Is there any update on this, on these antibodies and early detection?
Yeah, there's the good thing about women's movement is that they are driven by survivors. And the more we have breast cancer survivors, the more they're pushing the needle. And I'll give you how I was humbled by liquid biopsy. So that woman that I showed, after 5 years of beating triple-negative breast cancer, I was like, you're free, now start having babies. And she was going to have her second child. And somehow the OB-GYN did a cell-free DNA prenatal screening for her. And she had a P53 mutation in her blood. And I was like, what do I do? She's, pregnant, and I don't know how to interpret the data.
Yep.
So I said, let's do what we can do. She had the baby, and we just did some screening. And then that was the end of it. She had the baby, and until she developed a brain met. And then she said, I was carrying the baby. Maybe my rib was hurting. And that was when we found her metastatic breast cancer. The baby now that she was pregnant with, where we found the P53 mutation, was already 2.5 years old, right? So you imagine, we, of course, immediately started her on immunotherapy. She has complete remission. She's back at work. But imagine if I knew what to do about that, and I had treated her before she came in with symptomatic brain cancer. So I'm all about this now. There's so much we can do. And all these advocates, she's telling me, she comes to work every day and says, no, there's nothing about me in any of the guidelines. So I'm going to rewrite the guidelines by getting real-world data. So yes, there's antibody, there's vaccines, there are all sorts of things. So that's why this whole movement about cancer interception and CML, BCR-ABL, minimal residual disease, a disease that the only thing we had for was bone marrow transplant. Now, everyone with CML can expect to have a full life without dying prematurely. And everybody, Novartis made sure everybody in the world can have that drug. So I know we don't like pharma because the drugs are too expensive. But if we work in solidarity, we can have faster cures to everybody all over the world. So how do we do that? And I think we do it one community at a time.
I love the realistic utopia.
Yes! That's all I can hope for, right? Cancer is about being hopeful. All right, thank you.
All right, ladies and gentlemen, at this time, we invite you to help yourselves to the dinner buffet located in the Podar Lounge right across the hall. Kindly return to your seats once you've been served. Our program will resume promptly in 15 minutes. Enjoy.
Thank you very much. So I put in a few questions. I see Dr. Chung also is with us. Welcome to our panel. So I'm going to start with the first question, and this is up for anyone who would like to ask. How can we shift institutional funds and priorities to be more focused on prevention? I mean, I know that at Hackensack, there is this move now and this shift that this is an important mission for the center. But I don't see this as for every institution. And how can we ensure that this is happening not in just select institutions, but everywhere in the country?
I can say one thing that we've done at Fox Chase is, we justify our existence and the importance of prevention by the economics of it, by prevention screening people yearly or every other year. That brings money to the center, right? That brings people in who spend their healthcare dollars doing that screening, and although we hope they don't ultimately develop cancer, let's face it, along the way they're going to, and again that brings surgical money and other things. So we've made arguments that are very economic about why we should turn more focus of the center towards prevention because again of the downstream benefits.
Yeah, certainly a lot of places embraced rapid low-dose CT for lung cancer, and at $250, it's cheaper than most copays, and it's already changed the mortality, changed the early diagnosis patterns, and it happens to be good money for the medical center because you pick up all those early cancers and you get a chance to do that. So, unfortunately, dollars make a difference, and we have to figure out how to angle it. And the other way I look at it is in another way. I'm actually part of a startup in the employee health space where we're doing genomic risk stratification, and what is the investment for those people who don't know their risk. We identify their risk and we downstage them. More productive time at work, less mortality, cascade testing to help the family. So there's all kinds of ROI sort of equations you can come up with for risk stratification, but you have to get them to prevention and screening. Because the information is useless by itself. You made that point, Michael, earlier.
Yeah. And that brings me to the other thing you mentioned, so looking at large employers, basically, maybe pushing for all their employees to get the appropriate screening and early detection of cancer, and how can we just push for that, in the communities, like everywhere.
Yeah. So in the interest of full disclosure, we are medical oncologists. We treat cancer. I mean, that's just the way it is. And if you look at the health systems, Medicare pays for us as we get older, and we're all worried that Medicare will go bankrupt and won't be there for us. I look at the numbers. The US spends 17.5% of the GDP, and most of its health spending at the last month of life. Did you hear that? And it is in hospitals, fancy hospitals. So if we're putting patients at the center, we would know how to reverse that, because it is not sustainable. So, I've been making the argument to do prevention, because where I went to medical school, it was preventive and social medicine. But the American health system is not set up to care for you, because insurance changes, prevention is not even part of a benefit for most people. They don't cover prevention. So I think now that we're talking about accountable care organizations, where health systems are talking about population health management, where we have a lot of nurses as foot soldiers. Doctors are too expensive. I'll just get rid of all of them. Sorry. No, I mean, we all have to contribute to the solution. Otherwise, it is not sustainable.
The one other point I think I'll make, if you remember back to the big colorful boxes slide I had early on in my talk, many of the principal behaviors and things that we can do that lead to cancer prevention actually are beneficial for everything in health. They help prevent, alcohol reduction, getting more exercise, weight control. That's good for health across the spectrum of human health. So even though, again, we're sitting in this room talking about cancer prevention, and investment in those cancer prevention benefits actually is going to have a much broader impact.
But it is interesting to see that although we know that in lung cancer, low-dose CT, it's very efficient. In New Jersey, 48% prevalence of smoking, 1 out of 8 heavy smokers get screened for lung cancer. Yeah. And it's a huge outcome, 95%, outcome versus 10% if you have advanced stage, right? So this is obvious. And then, so that brings me to the question is that we know what we need to do well in life. Eat better, exercise, and be engaged, or do the right thing in the community and all that. How do we incentivize people in the right way to change their behavior? Because even if we have the next technology, easier liquid biopsy and all that, people don't necessarily it's not the right word, compliant, because the compliance sense of a obligation or forced adherence to it, to the recommendation, to doing the screening, so that it is fruitful at the level of a society. How do we do that?
Yeah, I mean, I think it's really, we have to rethink the system, the risk and rewards. I think the reason why, we are asking patients to change behavior, but we have not built the system that will allow patients to change their behavior.
So we have the Hennessy.
So the important thing really is green space is nice for you. We tell everybody, don't do this. Nobody wants to be told what to do. You have to make it easier for them to do it. And I'll tell you what happened to me. So every time I talk about breast cancer risk assessment, and I talk to patients about their risk, it wasn't until I actually participated in the wisdom study, right? Because imagine, I don't have a family history of breast cancer. You don't never personalize anything. When I did the wisdom study, I realized, oh my God, I came to America and I gained 10 pounds every decade. And if I continue along that trajectory, my BMI will be 100 by the time I get. So if everybody just gets their risk assessed, right, and then they're motivated. So now I'm a believer in digital health. Today, because I've been traveling, I haven't run, and my phone is saying, why are you not on the trail? Why didn't you do? So, just challenge yourself to different. Why did you not sleep last night? Right? Because all the things that we should be reminded to do, we can do them better if we have digital health and people pushing things at us. But we have to believe that we can do it ourselves without somebody telling us, don't do this. Because I think this is America. People believe in God, and God will take care of it. And I was like, yeah, but he can help you run a little bit faster. Right?
I think to also answer your question in a different way, I think we have to continue to evolve our technologies to make that screening easier. I think one of the biggest barriers of low-dose CT screening is it means a patient, who already, many have sort of a complex related, like I'm a smoker, and now, someone's telling me I need screened, and there's sort of a guilt transference going on there, having to go in and get this CT. And I think, we're not many years away from probably a blood test that can just one test done at the doctor's office once a year can probably detect that early lung cancer. And so I think the easier we make the screening, the more one-stop shopping, the better off we're going to be.
You can do biosensor in the toilet, and you have a wall that is transparent, and you can immediately have a doctor face to face with the doctor. I was listening to a futurist talk about
Confession,
this.
do it all at
It's
the same
not
time.
that far off, actually. But I will say that, at the end of the day, I think a lot of it comes down to money, because getting people, how many of you have got copays that are burdensome? We all do. And I think this is a huge issue. I like the ACA for having made it so that colonoscopy without deduction, right? So this is a barrier for everybody. But for genetic testing, we went from a test that was $6,000, took 6 months for 2 genes, to 80 genes in 2 weeks in the spit for $250. I mean, it's becoming accessible. Now we have to do the same for the prevention interventions, because that'll help us stratify, but we can't afford to have people walk away because of copays. And Fumi, you're doing such awesome work with the MRI studies, and you're right, the rapid MRI, it's such a game changer in terms of, it's way less than the cost of the copays that women have been paying. Everyone who comes to see me for high-risk screening, I tell them, don't try to game the system. You're going to spend your deductible every year if you're undergoing high-risk screening. It's just a reality. But for most of us, it's $1,500, $2,000, maybe more. It's not trivial. And that's with people, I'm employed, so,
Yeah.
it's the issue.
Tell us more about the ultra-fast MRI.
Yeah. So if you think about how cameras and technology has just transformed our lives, right? The same thing. MRI, when I first started my screening, because in the Midwest, people didn't want to have bilateral mastectomy. That was a huge barrier for my patients. And they will come to me from New York, from LA, say, is there something else we can do? And this is why there's power in clinical trials and also having colleagues. And so MRI has been getting cheaper and cheaper. Did you know that in India and in all the Asian countries, because of dense breasts, they don't do mammograms for anybody because they're just not going to pick up the cancer. An MRI is $50 or $200. It's not an expensive commodity. It became an expensive commodity because you want to only do MRI in hospitals. And now the technology is getting faster, cheaper. So when we first started our study, we did ultrasound, we did MRI, and we did mammogram, and we found more cancers with the MRI. But then each MRI is $7,000 and with a copay. So all of the guidelines we've given has been based on what we pay for it in America.
The other thing is that the MRI, what they've done to do the ultra-fast is simply take the cream of that, it's the contrast phase. You still have an injection of contrast,
Yes.
but it's that phase that is the fourth dimension of imaging. It allows us to see the blood flow. It predicts biologic behavior. It's the key, and it's
5 minutes?
7 minutes.
Yeah.
7 minutes.
Is the device different?
No.
Yeah, so the most important thing about the ultra-fast, because until you speak to medical physicists, we wouldn't know how to capture it. They can even get that most important phase to 2 seconds. Okay, when we adopted the MRI technology from Canada, we found that each woman that participated in our first study, they were in the clinic for half a day, getting all 3 modalities. And it took 90 minutes to do an MRI. For some reason, I went to get an MRI, and I vowed never to get into an MRI machine, even if it meant I was going to die. Right? It was loud, it was horrible. And we started studying it, and we realized that, yes, people would do it, but it was imposing, and people were claustrophobic. So if you focus on the patient, So guess what? Then they brought a breast coil. Then they did more stuff. So the company started doing things that were more women friendly. That's why they did a dense breast, or, abbreviated MRI. And that picked up more cancers in women with dense breasts. That's already done. So what we're doing with our protocol is abbreviated and ultra fast. If you combine both, we can get it down.
No,
But you have to study it.
no squeeze.
No squeeze. He can say that. Right?
Empathetic.
Because that's one of the things that women are asking for. So if you are designing it for the users, you would design it better. And that's why we're really looking for more users to give us feedback. And so the breast coil and the magnet to actually get, we use a 3 Tesla. I was at a meeting where there are 9 Tesla MRI machines that will actually pick up every molecule that's deranged. So the technology will get better. And we just have to prepare patients to do the studies.
At Montclair Breast Center, we screen a lot of high-risk women, and I do the statistics. I study all the breast cancers that we detect, and last year, 30% of the small breast cancers that we found were found on MRI for the first time, 60% on mammo, and then 10% other. Yeah, so, we're, more and more picking up these tiny, small breast cancers on screening. So, yeah, we're big advocates of MRI. I would just like it to go faster.
Yes. So part of why Dr. Weitzel is here, and I'm telling everyone that, this technology just needs to have people adopt them. And when you adopt them, you are going to be able to get it better. It's not perfect. So when we started in 2004, we actually called the protocol Chicago Alternative Prevention Study. And everyone said, oh, that's high risk. You're going to get these women. They're going to get breast cancer. And they don't. And so now in my clinic, what I ask is, are you afraid of never getting cancer, or you want a chance to survive? So when we give them the data that, people are living longer, right? So we have to demystify the idea that every patient is going to get chemotherapy. Many of these small cancers, we may have a different way to take care of them.
Well, our motto is that we want to put you medical oncologists out of business.
We will gladly go out of business. I just announced that I closed my medical oncology practice. I'm now a preventive oncologist.
So most of the patients that come every year and follow our advice, less than 5% of them need chemotherapy for breast cancer.
Yeah.
So, Michael, what do you think about, for example, using adjunctive things like Cologuard to get a higher rate of, next to going to an MRI machine for 90 minutes, a prep and a colonoscopy is just one of the top 10 fun things to do. Yeah.
Yeah. No, I think a prep and a scope is always going to be a huge barrier, right, in the population. There are some folks who are never going to want to go that route, and so that was part of the point, that I was trying to make in my talk, that we have developed these much more powerful technologies like Cologuard and ctDNA and RNA tests that I think those of us who are sort of in the space, and that if those are positive, it probably is going to lead down that pathway that someone was trying to avoid, meaning a colonoscopy and other things. But nonetheless, you can do a great job of pruning down the population who might then not have to go that route.
And also rural reach.
Yeah.
So people who do not
100%.
have access to centers, you extend the reach of your screening.
So I think we can't be so obsessed with perfection that everyone has to have the gold standard colonoscopy, right? What we need to do is just overall decrease rates of cancer in the population.
Yeah. Maybe we can ask Dr. Wendy Chung, because one of the questions that arose in the 90s was these families that have BRCA1 and BRCA2, were people afraid to even want to get tested, what do we tell their children? And so the breast cancer family registry, colon cancer family registry, ovarian cancer family registry, these registries have been in existence since the 90s. So Wendy, is there anything we've learned over the years about getting families in, studying them, and looking at what happens in the next generation?
Yeah, so I'll just make a couple comments if you can hear me based on some of the other things you've said. So as Jeff was saying, we've managed to get the price of testing down. I would argue we could get it down even further, and not just the testing itself, but the education and the implementation of using the information. A lot of that can be scaled and can bring the cost down and can do this continuous reinforcement that you were talking about, Fume. And I think in doing that and doing it with more, there's genomic information, and then as you're saying, there's real-time information with biomarkers, breast density, other things, Cologuard, tumor DNA, circulating tumor DNA, other things, but you can get what I think of as a forecast and then a nearcast. And I think you could actually do it. I'm going to be audacious and say that you could do the genomic assessment, not just for cancer, but for many preventable diseases. Take, for instance, diabetes, heart disease. You can bundle these together, and I think you could probably do it for less than $100 per person and really do it at scale for population health. And I'd like to see whether or not we could do something on that scale, where that information then becomes embedded in your EHR and helps trigger decision support so that you and your doctor can work together in terms of the right prevention strategy.
How do we navigate privacy with the data that we generate from all that? And I'm certainly an advocate for what you're saying, but at the same time, I also hear it from individuals that I don't, want my DNA circulating, and I don't want my information. Although, to be frank, I think all of us, our data is everywhere, and everybody has access to our data.
Does anybody in this room actually expect privacy anymore? I've got a folder with 6 different data breaches from different companies that, healthcare at this place, this company, another. Every other week, it seems I get one. I put credit locks on all my credit reports, so I don't know if we expect privacy anymore. I'm curious about newer generations, because I think there's a greater uptake than there once was.
Yeah.
Especially with the new generation who are they're on social media, which I think everybody knows everything about.
A little oversharing, yeah.
So it's.
I think there's a question.
My question is, how do you use the electronic medical record systems? They're so advanced right now. Oh, I'm sorry. So my question is, how do you build the infrastructure for population screening now that we can use the data in electronic medical records to assess which patients are eligible for screening for HBOC, for Lynch, for FH? How do you build that infrastructure?
Well, AI is that's one of the few things AI might actually help with. There's large language models, ways of probing the medical record. The problem is when I look at it as a physician, we have to code, right? I have to put in what is the diagnostic codes. And I'm consulting as somebody with an ATM pathogenic variant, for example. There's 7 different ways in that one patient that different doctors labeled it. And so you have 12 codes for just one thing. And I have some colleagues like Heather Hampel and others were looking at trying to get all their Lynch syndrome patients at City of Hope, for example. And there was 130 codes they had to consolidate to try and do the searching. So it's a good start, but we're a long way from making it easily penetrable to find people who are at risk and need this. Because I think the other thing is we have a huge reservoir of people who are survivors who are at risk for additional primary cancers, right, that we can identify predispositions for their families. Mm-hmm. And so we have in survivorship, genetics should be part of survivorship plans.
Right.
So I think we have a real call to action to do these things.
Because we have access to the data.
Yeah, I can tell you how we have used the electronic health record in our, because we were one of the early adopters of EPIC. And it was built for billing,
yep,
right? So when we wanted to start the wisdom study, right? Because wisdom is women informed to screen based on measures of risk. So the way we now recruit patients is to just send an email blast to everybody and we said you are eligible for wisdom study and you should participate. And if you know how many 70-year-old BRCA1 mutation carriers walked to my clinic, they didn't know their family history. They just responded to the email blast. Oh, and they found PALB2 or they found BRCA1. So I think if we use our electronic health record in imaginative ways and begin to do in-service where we train nurses at the bedside, everybody just participate. And most of the people that I'm picking up are actually nurses. They were going away, off work, and they just saw this and they said, oh, let me just participate in the study. And lo and behold, right?
Do you find that the primary cares are prepared to address these issues with patients, to administer the genetic testing, and then is there a referral out, or do they take care of those patients? There's not enough genetics providers to see all those patients. So what do you do?
I think in part this is what Wendy was just alluding to, that there's something called the Magenta trial, which talks about post-test counseling. So rather than starting with this, they showed an equivalence. Basically, there were no toxicities, let's put it that way. And so I think it's about scaling the expertise to the complexity. We need to be able to do all that. Oh, let me get my thing out of here.
Yeah. While he's doing that, the real, I think Magenta study and all of us, Dr. Chong, maybe you can respond to that, because there have been a lot of research done on return of results. How do you scale? Yeah.
Yeah, so as you said, with return of results, and there are many people who aren't going to have the family history. I think those are the ones where it becomes most jarring initially, but they accommodate very well to the information and they get plugged in and see the specialist. And so I think, as Jeff was saying, you put your resources at the back end, not at the front end with the pretest, but you put your resources at the back end in terms of making sure they get plugged into the right care and the right screening. I will point out the one thing, though, that maybe the questioner, I don't know if they were intending this, but the one thing to be careful about is you do have to have the system in place once you have those results, because it's not just that it's coded in 52 different ways, it's that in Epic it's hidden in 52 different places. And if you don't surface the information and then act on it appropriately, you can, from a legal point of view, a medical legal point of view, be held responsible. And it's just that you didn't have the time to plow through the chart. So I think each institution needs to decide where they're going to put that information and be consistent and have a governing body that decides for the institution. And it's not just BRCA1 or 2, but there's lots of important, genomic indicators essentially that you want to see on the dashboard.
In our system, with 18 hospitals connected with Epic, we actually are working with our institution data-wise and all that to do exactly this, to filter information, because you'll be surprised how I see people go get their medical history repeated over and over again from genetic risk factors, family history, but also we capture lifestyle factors, the social determinants of health at every encounter. At HMH, every encounter. So it's a trove of information to actually capture this patient and do, access with this patient and try to advise for testing.
I imagine that the numbers that are picked up for HBOC would be quite large.
Yeah, of course.
How do you filter through this? Like, how are you working
So
through that?
obviously there's no magic filter, right? We have to start somewhere, but I think that the bar is actually really low, because there's so little done. People go and they have a high BMI, they have smoking history, they have cancer history. It is repeated and repeated over and over again in Epic or whatever that is, EMR, but nothing was ever done. Sometimes to change the lifestyle, but also to actually measure the genetic risk factor, to really have a documentation to implement that. I think in the future, insurance companies will actually not force, but engage people to actually, based on risk factors, to have lifestyle accommodation. And frankly, employers should do this as well. I mean, this is good for the employers, but good for the employees and for everyone at the same time.
Sending messages to patients, so patient-facing messages
the goal is to sensitize and people who have risk factors and all that. Even in cancer centers, we see a lot of patients. The goal is obviously for the general population, non-cancer patient yet, right? But even in a cancer patient, the first question that someone asks you is that, will my kids get this? What did I do? Is it genetics? Will my kids get this?
Yeah.
So this is a great way, and I think we should start to think of screening at home, because we need to demystify the context of having to come to a cancer center. That's why the Hennessy Institute is great, because the interactive platform, but also it's completely not demedicalized, if you want to call it this way, right? And they have navigators, and it's all remote, a lot of it, and it makes it much more customer friendly, people friendly. And I think if we could do it in the community, in people's home, with kids and all that and information, there's a lot to win about this.
I'll just say on that point, because I totally agree with you on that. One of my collaborators and colleagues at Fox Chase, Carolyn Fong, and one of her collaborators, Grace Ma, have done a lot of work in first-generation Asian American immigrants, looking at home-based HPV screening and showing that just that barrier of going into the doctor's office and the exam and all of those things is obviously a huge barrier for women who often don't navigate the language well, and there are other sort of social factors. So I think you're right on the money there. Many of the things we do can be done from the comfort of your own home with a blood draw.
Yeah, and to just go back to, in 1997 we had the ASCO Cancer Genetics Task Force, and we were there expecting that oncologists would take over and do genetic testing and help their patients. 1997, we wrote the guidelines. We said it is the purview of oncologists. The geneticists didn't want us to do that because they thought we would not be able to explain genetics to patients. And we said, we break back news all the time. We spend all of our time in palliative care, in end-of-life care, and that we will take responsibility for the families that come to us, because they come to the consultation. They are with their relatives, even as they're dying. They just want to know, what should I do? So my database of 30 years was filled with promises that I made to young women who were dying of ovarian cancer, of breast cancer, and then saying, I don't know what the future will be for your daughters, but I hope I'm still here. We're just going to continue to do the research. So all these people that have put their faith in us to be advocates for them, they wanted faster cures. So we've delivered faster cures. We know breast cancer is curable. But what's the next decade going to look like for those young people who are now asking us, why is this cancer rates going higher and higher instead of getting better? And that's why I think we need to accelerate progress. And the science couldn't be better, but the hospitals and the health systems have not prepared for everybody to be aware that we're not where we were 30 years ago. We have solutions. We just have not been able to scale them. And I think the barriers of the 30 years ago was, your insurance won't pay for it. They're going to discriminate. There's privacy. If I were you, I wouldn't do it. You can't imagine how many people still come to us saying, if I were you, I wouldn't do it. I was like, we already have data that what you don't know hurts you. So this is why it's now the reverse, where we were worried about medical legal. Let's not put it in the chart. And now if you don't put it in the chart, the patient is not going to get the care that they need. So our medical legal team is like, put it in the chart, because they're relatives. Right? So I think I don't know if you are in healthcare, you're trying to have a solution, but the solution has to be tech-enabled with us taking responsibility for it. So I think, to go back to what Elias said, when will health system prioritize prevention?
Okay. You know I've been waiting
I
patiently
know,
to ask
the
my
young lady's
question.
been waiting patiently.
Right. First of all, thank you very much for this important discussion. And this is a good segue to me to ask my question. It has to do with lifestyle management. You've been talking a lot about prevention through diagnostic testing, which is so important. I'd love to hear your thoughts on lifestyle management as prevention. We're about to, I'm a co-investigator on a study in the myeloma division that will be looking at an intervention of 6 areas of lifestyle on MGUS and smoldering myeloma progression. If you get someone at that pre-malignant stage, what can this kind of intervention do to perhaps push back their objective myeloma-related biomarkers? So my question to you is, what do you see, and we're going to have folks wear wearables like CGM, continuous glucose monitor, fitness tracker, put them on body composition scales, so on and so forth. It's a 12-month study. My question to you is, what do you see at your respective institutions with regard to lifestyle management in the research area? Do you also see that there's more room for and more interest? It seems to me that there is, as well as patient adherence.
I would just make a comment that, there's people become evangelistic about this, and they almost need to. I'm thinking about exercise. So I work with Carol Fabian at the University of Kansas, and she's long championed weight control and exercise. And we have evidence now, great evidence, that we can reduce the risk of many types of cancer by 10 to 15% just by good exercise. And we're talking about some aerobic exercise. We know we can modulate, and we have science to go with it. We're modulating the inflammasome, our cytokines and things in our body. And so, getting into that. So this is something that clearly people can do for themselves. You were just complaining you didn't get a chance to get your run in. And there's a reason she looks so young, is that kind of exercise. I do spin classes 5 days a week. So, I believe it and I promote it, but it's not systemic yet.
Mm-hmm.
So I'll just say at Fox Chase, we actually have a pretty active behavioral science group in our cancer prevention control division, and we have a number of investigators doing studies in various areas. Like we had a new pancreas cancer diagnosis. We had a walking study, which was like sort of a low impact exercise study to look at how that impacted not only efficacy of the therapy, but also tolerance to side effects. We've also had a couple Fitbit studies in colorectal cancer patients undergoing therapy and in early adult cancers. So we're definitely big believers. I think part of the challenge is measuring lifestyle, right? Is challenging, getting people to sort of stick to the management issues you bring up. And I think the oncology field, of course, is very enamored with fancy new drugs and great diagnostics. So the fund of money out there to fund the kind of research you're doing is often, tougher to come by. But it's great.
This is true.
You're doing those studies, because if they can show, realistic effect sizes that you can actually, impact something like MGUS through exercise and diet and diabetes management, I think that's going to be very powerful.
Have you found in your institution that there's an appetite, patients have an appetite for this kind of thing, joining these studies?
Yeah, I think, one of the things that I've actually been observing is every decade there's a new big thing that comes into medicine. Right now, for women, it's menopause. And there's a reason why Novo Nordisk and Lilly are making blockbuster drugs that will be game changers for preventive oncology. How many of you have bought into longevity? Okay, I'm sure that's why you asked that question. There's a whole movement now on longevity that is really coming to oncology and to everything that we do, because metformin and many drugs that we give patients, when you actually look at their long-term effects, they help people live longer, right? And people are analyzing the real data, and they're coming up and saying, oh, we gave this drug for this, but guess what? This is what we found. Obesity and high BMI is the number one reason that we have a lot of rising colorectal cancer and breast cancer. Alcohol and tobacco, you tell people don't smoke and don't drink, but that's not life. They want to live a good life. They want to live and eat well. Okay, if you want to live well, what else can we do if we are going to be your doctor and not be judgmental? And I send my patients to our endocrine obesity clinic now because there's so many of my survivors who will do a lot better if they could lose 80 pounds. And they're doing it. They're doing it and they're feeling better. And no matter how much exercise and lifestyle I tell them to, it just didn't work for them. Right? So this is why we have to think about one size doesn't fit all. And because we now have this GLP-1 agonist, it's a game changer. Yeah. So for those who have money and can go to the gym 6 times a week, do it. For those who just want to lose weight, go to my obesity clinic and let's do it. Either way,
silver sneakers is cheap. Silver sneakers.
I mean, there's actually some really, just on that subject, those GLP-1 agonists, they appear to potentially do a lot more than just help you lose weight, right?
They do a lot more.
So I think we have to keep our eye on that, right? There are myriad health benefits.
Even in substance use disorders and things like this, you were just citing in
it's
this
a
long
game
string.
changer.
It does a lot, yeah.
It's a game changer.
Although there's some gastroparesis.
It doesn't matter. Right
Nothing's
now,
perfect.
we have new
Nothing's
drugs.
perfect.
Nothing is perfect. Do your measurements and get them on the drug. I can tell you, longevity, it's going gangbusters.
I just wanted to answer one thing of your question is that, so there is an appetite. Patients are generally very interested in participating on these sort of, accessory studies that look at lifestyle. I think the biggest challenge we've run into with the 2 or 3 that I've run out of my group is adherence is harder. When you feel really rotten from your chemotherapy and, you can't even get out of bed one day, sticking to your walking program or other things can be harder to do. So you have to build in allowances to the protocols, knowing that people are going to have a tougher time. It's different than coming in and getting the drug in the chair as part of the clinical trial. People's threshold to drop out is lower, but the interest is high.
Yeah, and I can tell you, in our high-risk clinic, we did 2 studies on alternative therapy because we actually found out our patients, when they know they have BRCA1 or BRCA2, they change their lifestyle. We didn't even have to tell them that. They're running marathons. They are out there taking, sun and vitamin D and everything. So they use more complementary and sort of lifestyle to manage their risk. And all we do is just screen for early detection. So I think that you can't do one without the other. You've got to help your patient stay healthy. So by watching these women grow older and then looking at what they are doing, they empower themselves by doing lifestyle. And they're out there and they are running and they're keeping their weights down.
I just want to respond. You said alternative. I'm sorry. You said alternative. I would like to suggest that it may be 5 years, maybe 10 years, but exercise and nutrition and things of that sort will not be seen as alternative because the research is showing that the impact that, as you said, the first speaker, that you could see a 15% change or something of the sort, and that's not a bad outcome measurement to change something by 15%. And then you think about adding exercise, you get your 15% there, and your nutrition, maybe you'll get 10% there, and your stress reduction, well, maybe you're going to get another 10%, and now you're having better results than immunotherapy.
Absolutely. I mean, that's been shown with palliative care, right? If you randomize patients to palliative care and chemotherapy, you get better outcomes. I think the lifestyle exercise is going to be big going forward. But what I meant by so, we're in Chicago, there are herbs, herbal therapy, Chinese herbs, so many things. And I want to bring back the Chinese herbs just for all of us. When ATRA, for those of you who did leukemia, I was at the American Society of Hematology meeting when the Chinese brought transretinoic acid and said this is a cure for a type of leukemia. We didn't believe it, right? Until the French did a randomized clinical trial. And do you know? Thankfully, this is why the global community has to come together, because we don't know where the cures are coming from. And I remember, I was like, this is unbelievable, right? That's been a game changer for patients with acute promyelocytic leukemia. So if you understand the biology and you now have people telling you this cures this cancer, you have to be open-minded. So this is why, to me, all of our research has to be done in global solidarity. We don't know where the cures are coming from. The H. pylori study, we would never have known about H. pylori and BRCA without the Japanese publishing that, well, their country, stomach cancer is the most common cancer. Why is it the most common cancer? Well, they did the H. pylori. They go about doing testing for everybody. And then they did the interaction with BRCA1, and now we know. So I think we're going to be blessed when we are open-minded and we go to different places to figure out the gene-environment interactions. Because if you go to the Caribbean, people will tell you, how many of us can afford to live by the sea in a blue zone? People are poor and they're living to 120. We can't afford that in America. So let's just get the GLP-1 agonist.
There you go.
We can all move to a blue zone.
Right?
Another Asian concept might be you only pay the doctor when you're well.
So I think, to your point, I think it's not in opposition. Obviously, lifestyle matters. I mean, I would argue that to fix medicine, you need to do two things. You need to teach the kids who are 5 years old how to cook, because they have no idea what food is about, and make sure that you obviously train clinician at being really good clinician, knowing medicine as a medicine, not just as a prescriber, right? But I think it's a combination of both, obviously, right? If you look at plant-based diet, I don't like to call it plant-based diet because it's on diet. I'm too French, I don't like the word diet. But plant-based diversity, so the studies that we have done on plant-based diet randomized after induction therapy in myeloma, post-transplant, so minimal disease, it doubled the duration of remission. There's no question about this. So lifestyle matters. If you look at CHIP in patients who have CHRP, clonal hematopoiesis, indeterminate potential. So the first reflex is to think, well, I'm going to get a leukemia. Well, only 2% of patients develop leukemia. MGUS also has strong fraction develop myeloma. But these patients, when they have this, the risk is that they say they're concerned that they're going to be a patient in waiting, right? But if you do the lifestyle changes, what makes a CHIP go into a leukemia or a MGUS into a myeloma, we think is just a stochastic accumulation of mutation. It actually, a lot of it is an inflammatory background that actually promotes the cancer. So that's where the lifestyle factors matter. And I think you can think of one or the other. The ultimate way will be in the future to be able to quantify the immune profiling on how you react to these abnormalities and how your change of lifestyle makes your immune system better. I think that's the long term.
What you're really talking about is adding the epigenetic to the genetic and working the two of them.
Absolutely. It's all in the gut.
For the sake of time, this is a wonderful discussion, but I just want to keep us all on time. And I just had one question for any of the panelists. Are we training the next generation of doctors to take care of prevention, or are we still doing one fellow every 3 or 4 years? And can we decouple cancer prevention from just oncology, or do we always have to have oncologists take care of prevention?
Oh, well, I can say that Dr. Hall trained with us as a card-carrying medical oncologist, and then he did advanced training in cancer prevention. That has to come from a commitment to it. And then he went for advanced training. I'm speaking because I'm a training program director. You choose to come and do oncology, and most fellows want to treat cancer. They want to cure cancer. I think they need to be exposed. And so in our program, the reason why we have had such a high rate of people picking genetics is because we made it compulsory for them to rotate through my clinic. Some will like it, some won't, right? But the question that is existential for us all in oncology now is, what is the workforce?
Yeah.
Who is going to train them and who's going to pay for it, right? Because if I train the next generation to be like Dr. Hall or to be like you, I can't afford to pay them like fellows forever. And if they can make more money in private practice or going to pharma, they're going to do that. So this is actually what the NCI and what we're all talking about, existential threat, right? Who is going to be in training forever to be paid as a preventive oncology when they can make a lot of money? So we're committed to training because I think I can spend my time hanging around young people like the next generation. But most training programs don't have that luxury. I don't know what you think.
I mean, I think you hit on a number of the important barriers. I think there's definitely others as well, right? It's not just the economics of wanting to get out and make money. It's that often, medical school graduates are coming out of medical school hundreds and hundreds of thousands of dollars in debt, right? And so just another year of fellowship and training is another year that's piling up. I think part of the other challenge too, and I think it is part of the kind of existential question here is where does cancer prevention best sit, right? Does it best sit in oncology? That almost seems like an oxymoron, right? Should it best sit in internal medicine, or should it sort of should preventive medicine actually be a thing of its own? Because even though we're very siloed into oncology, I think Jeff alluded to in his talk and others did, that the same diagnostic testing that can find all these cancer genes can find cardiovascular genes and lipid genes and all these things that probably should merge at some point. I think what this gentleman here has mentioned as well, and it should be part of an overall health assessment, right?
And I think, forget doctors. Okay, nurses should be doing this. So, we've developed a training program that I'll highlight briefly in my talk, so I won't give away all of it. But the fact is that everybody in the healthcare environment needs to have some element of this to help, because there is no subspecialty of cancer genetics. Wendy could talk about that. There's no subspecialty, and they're doing internal medicine +1 genetics, other diseases and +1. And we still have to increase the top level expertise, but the mid-level expertise is who actually has more contact with patients and beyond the cancer center, beyond the academic cancer center. I think that's where do most people get their care. So
Jeff and I have really had a long-term partnership where we have trained mid-levels, right? And I think this is where I think health systems should really feel free to deploy as many people as possible to be the boots on the ground, talking to patients. My program would not have succeeded if it wasn't for Terry Baker. Terry Baker was a nurse who was a breast cancer survivor, and she came and said, you need to do prevention. And I was still struggling to be treating breast cancer and all that. And she went, did in-service to all her colleagues. They are at the bedside, and she built our program. And that's the model that really gave me confidence that at the level of genetic expertise, we can have leaders, right? Maybe doctors will be leaders. But at the grassroots, it's got to be mid-levels who want to upskill, who want to be there, So everywhere in the world, We don't have genetic counselors. We don't have enough. And that's why the geneticists thought oncologists should not be doing cancer genetics. And we kept battling back and forth. But the thing is, cancer, the NCI, is very separate from the NIH because we have a National Cancer Act. As you get older, should we be waiting for everybody to get cancer? Or should we implement what we know now so we can break that trajectory? That's why the American Cancer Society is in every community. They do Relay for Life. I gave you the data. They've been collecting data from every community. We can map where all the cancers are, right? Because we now have the data. And if we have data on the pattern of cancer in your own community, a cancer center like this can say, we are going to reduce the top cancers in our community, and this is how we're going to do it. So that's why the strategy of doing community cancer centers, making them comprehensive, is really the key to get everything back to the community. And then the expertise, if you want to refer to Dr. Obid, refer to Dr. Hall. Let the elite academic centers stay where they are. But the patients need to be in the communities. And that's why I hope that that's the strategy that Hackensack has, where we cannot afford to train everybody to be a specialist, but the ones who are going to be specialists, they can be there, and then you can refer when needed. But we need to distribute it. It's a hub and spoke, right?
I agree. Thank you so much. Let's give a round of applause to our panelists for the wonderful discussion. And with this, I would like to introduce Dr. Wendy Chung, who's been with us on the panel. She unfortunately was not able to make it in person, but we were lucky to have her come and talk to us. She is a clinical and molecular geneticist, and she's the chief of the Department of Pediatrics at Boston Children's Hospital. And she's the Mary Ellen Avery Professor of Pediatrics at Harvard Medical School. She directs the NIH-funded research programs in human genetics of pulmonary hypertension, breast cancer, obesity, diabetes, autism, birth defects, including congenital diaphragmatic hernia and congenital heart disease. She has led studies to improve newborn screening for different genetic disorders. She is a national leader in ethical, legal, and social implications of genomics. And we are lucky to have her come to talk to us today about the ethical and legal implications of all that we're doing in genomic medicine. Thank you, Dr. Chung, for joining us.
Thank you. I'm sorry I couldn't be there in person. I actually lived in Hackensack for many years, and it would have been fun to be in my old stomping grounds. At the request, I'm going to talk about some of the legal and ethical challenges, but I will say they're even changing day by day, I'm seeing right now. But just to summarize, and I hope this is coming through clearly, there are clearly hereditary factors in many types of cancers. You've been hearing that all day today. Within this, you've also heard that germline, as opposed to somatic, but germline genetic testing can be an effective, I would argue, cost-effective and health-effective strategy as we think about both prevention, even more so than treatment, but for both of those. As I was alluding to, from a policy point of view, actually we celebrated our 10th anniversary in terms of gene patents, had opened the door for the ability to be able to do, I would argue, genetic screening on scale, and the cost has come down. Our ability to interpret this is scaled with AI and other computational methods so that we can actually do this more effectively, although, as I'll point out, there's still some limitations. And as we've gotten into this, I'll say that we've historically had started out by looking at the rare genetic variants in some of the genes that were highly penetrant or associated with very high risk. But clearly we realize that there's really a spectrum of genetic variants that include rare variants with high penetrance, intermediate risk genes with moderate penetrance, and even many genes with small effects. But in the aggregate, when you sum them computationally or mathematically together, many of them can have risks that are in the moderate to high effect. And really you have to consider all of those in addition to those environmental exposures. So I'm going to talk about a few things that are both ethical and legal, and I'm trying to keep this very practical. And I hope you understand that the take-home message is that I'm still very supportive of all the technology, but trying to help you think through the pitfalls and where people sometimes have issues or get into trouble. So one is that we consider that there's both an ethical and a legal duty to warn. So what I mean by that is that when we know of genetic factors, very oftentimes cancer factors that run in families, we have a duty to warn by telling the patient what those risks could be to the family and allowing them to either invite their family to talk with us or for that patient to invite their family to seek the information. But it's ultimately their family member's decision. So with that, it's not our duty to go out and hunt them down on Facebook or social media or LinkedIn or anything else. That's not our duty. But our duty is to be able to tell our patient what those risks to their other family members could be. Within that, as I was alluding to in some of my comments, things have gotten more complicated because of just the medical record has become more dense, more complicated with everyone contributing. And so it's no longer like your paper chart like it was in the old days. It becomes a communal medical record, and things, as I said, can be in places where you're not necessarily expecting them. So it becomes truly a partnership. And within that, I will say that when it comes to really important things like this, I know many of you do as well, but I always ask patients to repeat back to me those key points to make sure that they understood what I thought they understood. And it's a good teaching moment clarification if they didn't. I also use information sheets that I hand out or send electronically to patients so that their duty to tell their family members becomes much easier. All they have to do is pass it along, forward a message. They don't have to remember all the details or feel embarrassed if they don't get them right. They can simply pass along contact information and key points to their family members. What becomes challenging in part, though, is this is not static. It's not that a person's genes are not static. The genes, the variants they're born with, they're the same for the most part. But what has changed over time is our ability to correctly interpret and understand that information. So I'm showing you a patient that I really, it always for me starts with a patient and ends with a patient. And this was a patient that started me thinking about this, I don't know, it was probably about 13 years ago or so. The one with the arrow on the lower left is the woman who came to see me. She came to me having been diagnosed with bilateral breast cancer with a very strong family history, a sister, a mother, an aunt, a grandmother, all with either breast or ovarian cancer. And during today, you would have said, well, gosh, that looks like a classic breast ovarian cancer syndrome family. And so before she was diagnosed with breast cancer and just had that family history, she thought the same and went for genetic testing that included a panel of genes. At the time, this was way back in 2016. And when she had that panel of genes at Ambry, they did report out a BRCA1 variant. It's listed here. That at the time was a variant of uncertain significance. Or let me I actually said that wrong. It was in 2009 with the myriad test below. She had a BRCA1 variant that was a variant of uncertain significance. But she had understood that to mean that she had normal testing. So back when that was in 2009, she only had testing for those two genes. And so when she came to see me, I thought, well, we should update her test. We should do some testing that has panel with more genes. Maybe it's in one of those other genes that isn't BRCA1 or 2. But what surprised me is when I did her testing in 2016 from Ambry with a panel, they reported out a BRCA1 variant, but they reported it out as likely pathogenic. And I couldn't figure out why that was because she told me she had clean genes. She didn't have anything in her original testing, and I knew it had to have included BRCA1 and 2. So it made me go back and dig to see what the evolution was. And the evolution is what I put out here, which is that, in fact, in 2009, the variant was not known to be disease associated. It was of uncertain significance. But in fact, in 2014, Myriad reclassified that variant and thought it was the nomenclature they used was suspected deleterious, and then in 2015 even reclassified it again to say they had enough evidence to say that it was in fact deleterious. But the problem with our healthcare system was this information ultimately didn't get to her. She got the information in 2009, but the take-home message she took away was clean genes. Not that there was something that could actually change interpretation over time. And then due to a variety of things with various people moving, her doctor moving, her moving, there were breaks in the communication chain that she never got those updates. And so within this period of time, what potentially could have been something that was preventable, we just fell through the cracks. And so part of the question, and I know you know this, so I'm not going to go into detail, but with these types of genes, they obviously confer high risk over a life course of both breast and ovarian cancer. And so the same thing that's so valuable in terms of the ability to prevent is also from a medical legal liability point of view so dangerous because it is preventable. And so that's why I think we need really robust systems to take care of patients. So part of the question becomes whose responsibility? These variants of uncertain significance are actually very, very common. They're especially common in individuals who are not of European ancestry. So if you're Asian, Black, Latina, any place else other than of European ancestry, they're more common. And within this, many of them are going to be nothing. They're going to be benign variants that we simply haven't seen very frequently. But these missense variants in particular are difficult to interpret. We've gotten better with better computational methods, things like AlphaFold, to be able to see what these proteins look like in 3 dimensions, functional assays that people have done at high throughput and scale. But even still, there are many of these that we don't know how to interpret correctly, and the interpretation scheme tends to be relatively conservative. So there's been a question that I'm not going to answer today, but one of the questions becomes with this, who's responsible for keeping track of that and getting these reclassified? And for instance, for this patient, making sure that there's a continued line of communication back to that patient. I think the most important thing about all of this for you to remember with your patients, though, is that, again, to say that these variants of uncertain significance are not nothing, but they're something that you have to come back and get updates. And we have a transparent system called ClinVar where anyone, including patients, can see the most up-to-date interpretation of those variants if they like to. And they can always just come back to see whoever it is that ordered the testing and get an update from the laboratory as well. So I'm going to go on and just briefly say that just these monogenic or single gene factors are not the only thing we have to offer, though. We're starting to pilot different other types of integration of more information. So this is a woman that has a family history of breast cancer, very typical. And this is what I was alluding to in terms of common variants that individually don't confer very high either risk or protection. But in the aggregate, when you start putting them together, there's a distribution of these variants in the population such that individuals who have many of these common variants that go in the same direction may actually have risk that's similar to either the moderate or even some of the high-risk genes. And so putting that together, one can come up with what we call a polygenic risk score, and that sort of aggregate of both genetic factors of all different sorts as well as age. As you get older, obviously the risk of cancer higher, and then environment and lifestyle, all of those can put you over a threshold of liability. And so the question is, how do you actually put that together, both from a mathematical point of view, and then how do you ultimately deliver that to patients in ways that they can understand? So we've been doing this in a study called Emerge. So it's an NIH-funded study called the Electronic Medical Record in Genomics. We actually do it for adults for 10 different conditions, everything from breast cancer, colon cancer, prostate cancer, type 2 diabetes, obesity, cardiovascular disease, hypercholesterolemia, renal disease. But again, many of the things that are most common in adults. And for breast cancer, we've been using Boadicea as a model. We luckily have a pretty well integrated risk score that takes not just those monogenic factors, but also family history, these polygenic factors from 313 different genetic variants, breast density on mammography, body mass index, everything reproductive factors, but putting all of this together. And the beauty is you can come up with a simple score. And with doing that, You don't have to weight it in your head or try and think about it. You can just get a very simple score that comes out of this. One of the challenges, though, just to say it, is that these polygenic risk scores, so part of this computation that goes into it, we're doing our best to estimate these, but most of these have been estimated based on individuals of European ancestry. And what you can see here is these distributions using the same genetic variants, individuals of African ancestry on the left, other populations, AMR actually as the Latina population, South Asian, SAS, you can see that these distributions are similar, but each a little bit different. And so we really have to put the work into figuring out and understanding which variants are relevant to which populations and how to weight those variants to come up with the appropriate risk score to be equitable as we're doing this. In doing this, I won't go into more detail, but it comes out looking as a report like this that's summarizing all the different types of variants. And in doing this, I call it bending the curve, but being able to see what your risk is, and that as you get older and as other variables change, that risk actually changes. So it's not a monolithic lifetime risk. It's actually changeable. And by some of the interventions, one can actually get, I think, a positive behavioral feedback loop to modify some of those. So let me just, for a couple minutes, talk about what some patients get concerned about, and I'll try and demystify some of this. So many patients get concerned about genetic discrimination. Is there some way this information could come back and bite them in some way, where they could be have their insurance taken away, their health insurance, their life insurance, where they could be fired from a job, where they could be socially stigmatized in certain communities with marriage prospects. So there are all these different types of concern. I will say historically, I think the concerns have been much greater than the reality. There hasn't been much actually proven case precedent in terms of this happening. There is always the possibility of subtle things that can't be proven, but for the most part, this hasn't been such a big issue. And in part, this is because of a federal law that was placed in 2009, the Genetic Information Non-Discrimination Act, which protects, not perfectly, but especially protects health insurance, the ability to have your rate differentially raised or having that taken away from you. There are some limitations in GINA, though, and it is not perfect in terms of not covering, for instance, life insurance or jobs. I will say, just parenthetically, that although I had felt like most people were very reassured in terms of discrimination, there has been a real spike, I would say, in the last even month in terms of concerns coming in from either clinical testing or research testing. But as there's been discussion of federal registries of information, I do think it's some misinformation has gotten out to patients in terms of what might be happening with their data. And so we've been working hard in terms of trying to really explain what is and is not happening. But I will say I think there's more concern now than there had been for years. The other thing is that many people are now getting genomic tests for other reasons. They're getting something where they're literally sequencing all of the genes. And with this, we weren't intending to find genes that were relevant to cancer. So they might have been coming in because their child had autism and they were concerned about an autism diagnosis. But when we do an exome or genome sequencing, we bump into, incidentally, some of the genes that confer high cancer risk. And we struggled with this as a community for a long time and ultimately decided that there were a little less than 100 genes that were important because they were either life-threatening, life-altering, and had actions that could be taken. They were preventable conditions, and that therefore we should give people the option of knowing this information because it was kind of bundled in with the other things. And so the most common of these that we run into are the cancer genes, which is why I'm mentioning this. And they sometimes, in fact, it's not uncommon, I've seen them be without a family history, or at least not a known family history when the testing was first done. And so within this, we always give patients the ability to decide whether they want this information or not. The vast majority of them do decide they want their information, except sometimes testing is done, especially in pediatrics when a child is very acutely ill, and it's just not the right time to try and digest that information. So families may defer at that point, either defer forever or defer right exactly at that moment until they get through the acute crisis. But it can be quite helpful to the family, the parent, if a parent has this, and even long-term to a child as they grow up. Some of the ways that people use the information is for their own health, also, as we talked about, with the duty to warn for other family members. But one thing that sometimes comes up as controversial is, will they use it for reproductive purposes? So will they, when they're pregnant, test a fetus to see if it has a BRCA1 or 2 mutation, or even potentially use it in terms of in vitro fertilization and pre-implantation genetic diagnosis? And so in that particular case, one goes through, as I said, in vitro fertilization, does a sample of the embryo without damaging the embryo, and doing genetic testing. And in these cases that might have a dominant inheritance with the 50% risk of transmission, preference either by gender, if it were, for instance, association with breast ovarian cancer, or with the BRCA or Lynch syndrome or other Li-Fraumeni or other genes that might be seen. I will say I've seen this done. I've also seen many people think very hard about it and decide that, they feel good about the methods of surveillance and prevention. And so I wouldn't say there's a monolithic answer in terms of this, but it is for individuals not going through in vitro fertilization for other reasons. It's not trivial in terms of both cost as well as energy that it takes to go through the IVF. The concerns that people have also had in terms of some of the privacy is not really just about genetic discrimination, but some of you may have heard about the Golden Gate Killer, or the Golden State Killer rather, and even genetic information being used in the criminal justice system. And so with this genetic information, for those of you who have done something like Ancestry.com, can be used to connect family members, even individuals that might be distant cousins. And to the same extent, with some of the rare genetic variants, this information could also identify within a family other individuals who are related. I don't think from a legal point of view this is completely sort of solid yet at this point, but many people are thinking about legislation that would protect privacy. Obviously, your medical records are always private, your genetic information in the medical record private as well. But when it comes to other places where your genetic data might be sitting, if you had 23andMe at some point and you didn't realize that 23andMe is going through some changing of the hands with that company, or other places where your data might be sitting, people get concerned about the privacy of this information as well. So let me pause and end that by saying, I just want to make sure you got the right take-home message. I'm still optimistic in terms of what the information can do, but I do think we do need to listen to patients and their concerns, and where we can, even outside the medical system, be able to provide reassurances for them to make sure that they can access the care and the information they need. Thank you.
Thank you very much, Dr. Chung, for the wonderful overview of this important aspect of genetics. I don't know if anybody has any questions for Dr. Chung.
Yeah, I have a question. So we get a lot of patients who have childhood cancer, and because of, as you said, a child seriously ill in the hospital with childhood cancer, and then the mother or the parents are at risk, and then of course the risk to the other siblings. How do you expect that those children and the families will get identified and then taken care of in health systems such as Hackensack? So I'm talking about children, childhood cancers, because Emerge Network has been focused on annotating variants of unknown significance or, pathogenicity. But the question really goes back to the original challenge that Steve Friend had, where children were identified with pathogenic mutations that had implications for their parents and for other family members. So how would you advise that health systems take care of that?
So I'm not sure if I completely got that, but clearly if there are mutations that are identified that are pathogenic, Again, with the duty to share, hopefully this information gets shared within families, and targeted testing for that mutation is trivial to do that. You know this well, cascade testing, and then ultimately, hopefully, delivered with the right information about what risk when for whom, be able to plug folks into the screening programs and prevention programs for that. Obviously, the mutations, it's a nuanced question. The types of cancer and mutations that we see in children may or may not be seen in adults, and in fact, sometimes we see de novo mutations in children, so that we only see it in the child. It actually ends up not running in the family, it's solely in the child. It wasn't your question, but I'm just going to throw out something provocative so that maybe you have something to talk about tonight. We're even doing, in the introduction, you alluded to this, but I'm even doing a study now that's called Guardian, which is about newborn screening. So it's about population-based screening using the genome, with the idea that it's really to be able to put a system of care in place. It just has to happen. And so newborns get screened for phenylketonuria. And in that context, we've been taking those dry blood spots and doing genome sequencing and reporting out information that's relevant to very young children. So we don't report out in general cancer genes, but we have, for instance, included retinoblastoma within that as one of the genes that's relevant to a very young child, and to leave no child behind in that process. It's a pilot study. We have a lot to learn in terms of doing this, but this is what I was alluding to, that information then does sometimes identify things that we reflex into the family about and then plug them into care. So it's not just about testing, but it's what I call onboarding and integrating into care as well.
Dr. Chung, I just wanted to ask you a quick question just as a follow-up to that. You said you report out the retinoblastoma. How about APC or FAP, in that we can see impact on very young children in the first 1 or 2 years of life? Do you report out that?
Yeah. So it's been a challenge. I will say we've gone slowly at the beginning to make sure that we knew what we were doing and we could correctly interpret these variants, given that it's difficult to have a functional assay when it comes to cancer predisposition. So the short answer is no, we have not yet started doing that, because I didn't want to get ahead of myself and then trip and fall. We've been thinking about staging how we would come out with, we go through each year a new revision of the gene list that we go through. So we have things that we're thinking down the road, but it's important. And to be honest, this is not focused largely on cancer. So we included retinoblastoma as our one token pediatric cancer gene to start with.
Dr. Chung, you mentioned the genomic indicator you use in your EPIC system. And so if a VUS is reclassified to be likely pathogenic or pathogenic, who at that point is addressing that with the patient?
So that's,
and how are you alerting the patient? Like, how is that taken care of?
So that's, I guess, what I'm trying to bring to your attention is that right now there's no system in place to do it. And I've written a lot about this, about whose responsibility it is. And the problem right now is it's one of these. And what I mean by that is that it's officially, legally, it's whoever ordered the test is responsible for that. But there's nothing that triggers that reanalysis in an automated way. So if the laboratory happens to see the variant again and happens to classify it, they may issue a revised report, and that revised report would go back to the ordering physician, and then that ordering physician is responsible for returning that to the patient if they can find them. If by reasonable means they can use last known address and find them. But there's not necessarily in fact, there isn't an obligation or automated system to do that, and it costs something to do it. And so there's no money still getting paid into the system, which is why it hasn't evolved into an automated system yet. A health system could decide they wanted to do it. And so we've been experimenting with some of things like that at my hospital, but it's not well developed that I've seen in many places.
Got it. So they don't update the genomic indicators if the variant has been reclassified. That's not done automatically.
That is not an automated thing unless your health system set it up to be so.
Okay, thank you.
To
add to that question, so this whole question of whose duty is it? Does privacy trump duty to one? And I think the reason why genetic testing labs report everything and give the result to the patient is because the contract is with the patient, right? And that's why, at least we are asking, when you just order a test and you're not involving a genetic counselor, then the health system should make sure that there's follow-up, because you are relying on the patient. We just talked about sending the kit to the patient at home and the patient having access to the portal. So most genetic testing labs have genetic counselors that work for them. They are trying to solve this problem because every hospital cannot do genetic testing. So they farm it out to different labs. So this is why at this moment, at least what I tell my genetic counselor is that all the laboratories have genetic counselors working for them, and that it is the responsibility of the lab, when they do this test at home, to make sure the patient has a copy of their results, and that they bring a copy of the results to our counseling. Because otherwise, we cannot scale genetic testing, right? So the duty to one is with infectious diseases, right? Because contact, you want to make sure tuberculosis is not going on in your community. And this is why you need to raise the level of awareness and education of everybody. It's your responsibility. It's personalized medicine.
So it's important to educate the patients that they are their best advocate, and they need to keep up with the laboratory on a periodic basis and contact the laboratory and see if there are reclassifications with those VUSs.
Right.
But when it's in the medical system, when it's in the genomic indicator, and it's there, and if it's been reclassified but it's not in the indicator, that's concerning.
Yeah, well, the issue really is that we will not get to personalized therapy and personalized treatment if somebody else is taking responsibility for your health, right? This is why when you're talking about patient-centric, we are a partner with the patient, right? This is why doctors are burning out. They are leaving the field. There are no genetic counselors. So everybody always talks about there's not enough of us. But what about the patient as a partner, right? So this is why I'm really saying every encounter should be that people are trusting the health system and they're communicating and they are being empowered. But if it's all, well, my doctor is going to fix everything, then it doesn't work. We would never get there.
So can I make it more complicated? In the field of bone marrow transplantation, when we deal with donors, especially with anonymous donors, one of the ethical questions that we have, let's say you had an allogeneic transplant and a few months later you found a new mutation in your patient that you believe came from the donor. Who is responsible, and are we responsible to inform the donor and even go back to the donor and test them?
That's a Lucy Godley question.
and that happens a lot, and it's a very, very difficult question.
So I will say, I don't know the same thing happens in terms of gamete donation as well, so various different donation strategies, and it always depends on what the consent is up front.
Yeah. Wendy, I would say you should refer to the work that Lucy Godley has done with the transplant registry, because it is happening now that you actually don't want, so they're trying to get everybody who donates to do genetic testing before donating.
I see.
Right? Because you also don't want to give somebody's bone marrow back to the allogeneic transplant that is going to be, even the related donors, they're trying to get everybody tested now. And the question is, they have all this panel of genes that they can test for, for hematologic malignancies. We don't know the penetrance. We don't know what they do. Trust me, come to our cancer genetics conference next year. But there's increasingly, that's the question that is happening in transplant. Where do you get the bone marrow, and do you transplant a mutated bone marrow?
Thank you very much, Dr. Chang. Thank you very much for
Thank
this
you.
lively discussion. And with this, I would like to introduce our last but not least speaker, Dr. Weitzel. Dr. Weitzel is a professor and he's the director of the Division of Precision Prevention at the University of Kansas Comprehensive Cancer Center in Kansas City. Dr. Weitzel is board certified in clinical genetics and medical oncology. Dr. Weitzel's research has been first of all, in training programs. I'm actually one of those students who were at the training program. He also has done a lot of translational research in genomic cancer risk assessment, chemoprevention, targeted therapy, clinical and psychosocial outcomes, genetic epidemiology and health services, and hereditary cancer in Latin America and Latino population. He is a member of the American Society of Clinical Oncology and NCCN guidelines, and he is a recipient of the American Society of Human Genetics, the Arno Motulsky-Barton Charles Award for Excellence in Human Genetics Education. So with this, thank you so much for coming and being here today.
Thank you, Les. And again, I've inherited two things up here. One, a lot of the concepts that I hope to talk about have been at least broached in different contexts between the speakers tonight. And second, I'm supposed to be halfway done already by the schedule. So I'm in honor of all of you, I will skip a few slides. I hate it when speakers do that. They go forward quickly, but I do want to honor your time tonight, and I appreciate your attention. So I'm going to start, though, with this title slide, which really shows, this was a cover of Science magazine in 1994, and that was because that was when we were so excited because BRCA1 had been cloned, and this was an artist's depiction, you can see on the clothing, that parts were cut out that were related to loss of body organs and things like that, that were really evocative. And this was considered one of the greatest and most strenuously fought for challenges of that era. But, and so I'm going to talk about current status of genetic testing guidelines, review data on the prevalence. So I'm going to talk about why should we be screening pretty much all cancer patients? Why should we be more inclusive? I'm going to talk about the kinds of technologies that you've already heard about, but I'll try to wrap it together in terms of how we approach things. And then to consider how increased precision can enable interception and prevention. We all use our own timelines, and this is one that I like. And so in 1990 was when BRCA1 was localized, but at the same time, P53 was linked to Leigh-Fermani syndrome. The APC gene was identified about the same time. The mismatch repair genes for Lynch syndrome were found about the same time. So it was really a very exciting time. So as a trainee in oncology and hematology at that time, I segued into genetics, much like Fumi did, and we all were so enthralled with the concept that we can identify people who have extraordinary risk, and we can do things about that. The next 2 decades, though, I'm really most proud about the fact that we now have evidence for the advice that we offer to individuals who are found to be at high risk. And so that was really critical work that was done. And then about the mid-2013 era was Angelina Jolie and her announcement, and we went from Sanger sequencing, which again, $6,000, 6 months and 2 genes, to next generation sequencing, which get us scaled way up in terms of the genes we could identify. And literally the day after the patent was disallowed for BRCA1 and 2, there were laboratories offering multi-gene panels that included BRCA. And so we have a whole nother realm. And then the last phase that I will touch on will be the fact that we haven't, like Wendy Chung was talking about, we've moved to whole genome sequencing-based technologies. It's never been that we didn't want to start with the whole genome. We never wanted to do a small slice. We always wanted the whole genome. It's just the cost was prohibitive. But it is not any longer. And I'm excited to think about how we can do this in a better way. Virtually every common cancer has a genetic component. outside of some of the viral ones. So thinking of hepatitis, thinking of cervical cancer, which are viral etiologies, but virtually every other common cancer has a genetic component. Most well-studied is breast cancer, and so we had it right from the beginning. BRCA1 and BRCA2 are the largest attributable risk for breast cancer when thinking of a genetic component, a genetic attributable risk. But the other genes, PTEN is Cowden's disease, P53 is Leaf-Romani, ATM, PALB2, CHEK2, they're called non-syndromic genes, but they all do breast cancer. And then there are other genes that probably aren't many left that are significant, but polygenic risk, and I'll touch on polygenic risk. Again, it's the idea that we have management guidance that makes it compelling. We must find these individuals. We can do cascade testing, so testing the adults in the family. We have evidence for risk reduction surgery. In fact, oophorectomy, removal of the tubes and ovaries, as a prevention in BRCA carriers, reduces all-cause mortality. This is like grade A1 advice. We can't leave anybody undiscovered in that regard. Targeted therapies, thinking PARP inhibitors, increased surveillance. We demonstrated in prospective studies that adding MRI to mammography increased our catch rate and decreased the stage at diagnosis. We downstaged reliably. And I was pretty convinced we'd never get any mortality data because nobody's ever going to be randomized to not getting MRI given the current circumstance. But in fact, there's a mortality study that was just published. So we now have even evidence that breast cancer-related mortality is decreased by the addition of MRI. So we know what to do with these individuals. This set the stage for what we do for a lot of people. The criteria are Byzantine, so I'm going to skip over. I was on the NCCN Guideline Committee for 19 years, and really these is all triple-negative breast cancer, all pancreatic cancer, all ovarian cancer. We're getting to all cancer. And in fact, ASCO and SSO last year revised to recommend testing for all breast cancer patients going forward. The surgeons have been advocating for this for some time. We can debate that, but I think that it doesn't matter if the yield is only 3% over 65, it's still important. But also the nuance, you don't treat everybody the same way. So we have a problem with treating everybody with BRCA the same way, and we have a problem with treating people who don't have BRCA but have other genes like we treat the BRCA carriers, meaning with the same gravity of interventions. And so I'm just pointing out here that on the left is a graph from CanRisk, which is a great tool for this, showing that a BRCA2 carrier female who's 35 and unaffected, her lifetime risk broaches 60%. And if you look at that from her age currently at 35 to 65, think about the 60 or so MRIs she's going to get in her lifetime. So she might reasonably, especially if there was a lot of mortality in her family, decide that she wants a mastectomy to obviate some of that. I'd rather see her get into other forms of prevention, but it's reasonably, so you should discuss risk reduction mastectomy with that individual. But you take the exact same mutation, a woman who was unaffected, but at 60 is discovered she's got BRCA2, and look at the difference in the trajectory. Just over 20% of risk over the rest of her lifetime. Is it right to be talking about mastectomy? So part of the nuance of cancer risk counseling and well-trained people is to know that there's both risk-specific issues and age-specific risk differences. Now, ovarian cancer is a timeless disease, unfortunately. So there isn't an age, I've been known for this, I actually got quoted at a meeting just recently, that there isn't an age that I wouldn't do an oophorectomy in a woman if I would in fact do laparoscopic laparotomy and treat her for ovarian cancer. So if she's not too old to treat for ovarian cancer, it's not too late to prevent it. So knowing about ovarian cancer risk is actionable at almost every age, and it's one of the most important mortality-reducing interventions we can do. I love this figure because it blends what we know about ovarian cancer risk issues. So BRCA1 and 2 were by and large the most important genes, but then we have the mismatch repair genes. So Lynch syndrome, we forget that it's not just colon cancer, it's uterine and ovarian. And then on top of that, we've got the BRIP1, RAD51, C, and D, and so they all are tiled in their risk, and so we now know the way to think about this. Now, if we want to move to a broader population, however, we have to understand what it's like when it's not highly selected. So we're becoming more inclusive. So anybody with breast cancer, Okay? Well, they don't all have family history. And it turns out that family history harbors a modifiers of the risk. And so this is a study called the Carrier Study. They took all of the legacy studies, the Women's Health Initiative, the Cancer Prevention Cohorts 1, 2, and 3 from ACS, Black Women's Health Study, all these different studies. They put them in. Fergus Couch was a PI, and we did multi-gene panel testing because we didn't know what it meant to be population-based and have an ATM or a check two. But this tells us what to expect, and like we expected, all of these risks are attenuated, but now we know how to counsel people if we found a variant, but we hadn't been looking for it. We weren't anticipating it. And I look at multi-gene panels this way. It looks complicated, but it's not that complicated. On the far left, it's pancreatic and breast. If that's what's in the family, I'm thinking ATM, BRCA2, PALB2. If it's pancreatic and melanoma, it's CDKN2A. On the other end, breast and ovary has the greatest overlaps. But the point is that I use multi-gene panels to explain complex phenotypes in families. Not many families are monomorphic in terms of what is their ailment. So we have genes that are associated with a well-known syndrome, think BRCA or Lynch syndrome. The highest cancer risks, we know what cancers are associated because we've been studying them for decades, and it's clear implications for family members. If you don't carry what your mom had, you don't have the risk. But the problem with the moderate risk genes is all those things go out the window. We don't know all the cancers associated with them. The risks are less, and there's very significant modifiers of family history and things. And so when you're negative for what your mom had, it's less impactful. You may still need screening. So it gets complicated. And then when you're thinking about 80 gene panels and bigger, they're really for stuff that we don't know much about at all. They've been associated in a study or two. They're not quantifiable yet. As I often say, if it has to use an odds ratio or a hazard ratio as a how many fold risk, it means they don't have enough data to give it quantitatively. It's probably not actionable. Now, there's also the problem of missing heredity. So while we thought that we'd find all these other genes to fill in that pie chart, the reality is we're probably missing some of the heredity. So these are families that were, this is a study from Mary Claire King's group, and Tom Walsh had reached out to me because they were evaluating high-risk families that had uninformative testing. It's uninformative if it's negative and doesn't explain the family history. And what they showed was by doing deep sequencing into the introns, literally at a genomic level, that they were finding variants that would alter splicing and could be considered probably causal. This one was of interest because these are two Mexican families, and I do a lot of work in Latin America. So I'm actually doing a study right now to see if we can find more recurrences of this same variant. But we call this missing heredity. So why is a test negative when it should be positive? Sometimes it's missing heredity, and there are different ways technology is helping us. Now moving to the concept that Dr. Chung was also talking about, polygenic risk scores. So genomic risk versus monogenic risk, albeit rare. And again, this is just showing the contrast that for the monogenics, high risk and not common, polygenic is very low risk but common. And overall, they make up a part of that pie chart. And so we're now getting tools in both realms about how we can better stratify risk. And so the polygenic risk scores, again, just taking all these SNPs. If you take one SNP, it's a G or an A at a given spot, and it's like 1.01 risk compared to 1. Well, that's meaningless to somebody. But it turns out if you tile in this case, 77 of them, you can stratify risk in a normal population of as high as 30% at the top, down to less than 5%. So maybe the ones at the bottom don't need screening or don't need it more than once every 2 years, and the ones at the top probably deserve MRI. The thing to remember, though, when you get into these is that even the rare highest risk is not enough to consider mastectomy, by and large, as a risk reduction procedure. Wendy brought up the issue of equity, and this is just showing that when you take these disparate curves on the left at the top, these are different populations, but you can mathematically, if you are careful about it, correct them so they align, which is the next one to the right. And I've worked with a number of, with both Myriad, with Myome and other companies, trying to develop these four people and trying to become more multi-ancestrally correct. And this is a study that was showed that we could, by using whole genome sequencing with many more SNPs, which allowed us, that's single nucleotide polymorphisms, which allowed us to then create ancestry-specific risk profiles. And you get the ancestry SNPs. There's SNPs that tell us whether you're from Asia. It turns out that if you aren't looking deep enough, Amerindian, so think of people like indigenous Americans, and Asians actually overlap if you're not looking deep enough. Why? We think because of the Bering Strait between between Alaska and Asia was probably populated. It took 10,000 years for the peoples to populate them, but they have SNPs in common. It's interesting how anthropology and genetics intersect for us. Nonetheless, we can now have tools that are clinically validated and that are able to discern multiple continental ancestries. So we're getting, to some extent, over the equity issue. At least it's accurate. But you'll notice that when you look at these odds ratios, this 1.68, that's the highest. That's per standard deviation. When you get to some of the other ethnicities, they're not as powerful, but at least they're accurate. Now it turns out that you can take these SNPs, integrate them with all the risk factors that we knew about. So think Tyrer-Cuzick and these ways of estimating breast cancer risk. Well, if you take polygenic risk score, a gene, a monogenic variant that's moderate risk, lifestyle hormonal factors, and then you put the whole model together, you see how it spreads out that curve. Because we all have patients who have a mutation and have nothing, and we have others who we wonder how they could be so severely affected having the same mutation in two different families. And a lot of it's about those modifiers. And that's really about the lifestyle risk factors that are so important. And you can take the same thing for the genes themselves. So even BRCA can be spread out to very high risk and risk that's almost not necessary to think about surgery anymore. So you start to spread out those risks by all the things that are modifiers. So I eat this up as a form of greater precision. You know, we all wonder why PALB2 can have families that look completely devoid of anything and others look more like BRCA1. And so these are ways to start to help us do that, and we're starting to spread that risk out. But then when you put it into clinical implementation, the challenge is the outliers. So somebody who's got a very bad polygenic risk score in a cumulative way, multiplied by a CHEK2 variant in this case, and they were telling a young woman that she had an 84% risk of breast cancer. I wouldn't even tell a BRCA carrier that. So we're a little hesitant to be given that advice or to accept that without more data. But we're getting more data, and we will get there. But I do think this is an important concept. Now I'm going to segue quickly to this other concept, which is precision medicine and what we discover accidentally. So remember, when you sequence the tumor, you're actually sequencing the germline with a few added features, right? Every cell starts with the germline. It just, all of the mutations are layered on top of that. And so this was a study that we published a number of years ago when we looked at all of Garden's data, 10,000 people who had liquid biopsy. And what you're seeing in the blue is 50% allele fraction. That's what you expect for an inherited thing. The yellow at the bottom are all of the tumor-specific variants. And what we showed was that out of this group, we could see over 150 people who had germline, but they weren't doing germline testing. So we really need to understand that when you do tumor sequencing, you can see the germline. And this is data from, for example, Sloan Kettering, where they were doing tumor and germline sequencing in tandem. And what we see is that for every cancer type, the yield is pretty interesting, over 10% in most cases, some of which is causal and some of which is just a passenger but is relevant to the family. So, and the more important part is that families did not meet the NCCN guidelines for respective pathogenic variants for 74% of these. So that means we're missing things by family history-based criteria. And testing all cancers reveals many actionable PVs and among patients who would not have been offered testing based on current guidelines, and certainly not before they were diagnosed with cancer. So why are we waiting for cancer to do testing? Just to show you that germline genetics is important for clinical trials, this is just the growth in clinical trials using a germline endpoint or parameter in the study, most of which is at the top there, BRCA, because of PARP inhibitors. But think immunotherapy and Lynch syndrome. You can think of a lot of different categories that this is relevant to. And again, it used to be that, thinking about germline genetic testing for women with breast cancer, shifting the paradigm from whom to test to whom not to test, to universal testing is needed to win the war against cancer. I think this is really where we're moving very quickly. How are we doing with the guidelines, by the way? So this is Alison Kurian's marvelous work because she has done such great work connecting SEER registry data, so what's happening out in a population-based setting, with genetic testing vendor data. And by reconciling these two, we know how many people with a disease indicator are getting testing. And pathetically, men at the top are men with breast cancer. Well, there's so few, but they were at least getting 50% of them tested. The yellow line is the ovarian. It's more than a decade we've been saying test all ovarian cancers, and here we are a decade later, we're still testing less than half of them. So we are failing these individuals with cancer. We are not getting the reach that we should for almost any hereditary syndrome. So how do you get there? Well, one of the ways to do this is, how do we train more people to do it? This is what was alluded to earlier. This is a course that I started at the City of Hope 2001, and basically it's a 100-hour course. We called it the intensive course to be the antithesis of the weekend course that a vendor might teach you how to fill out requisition forms. And so we did this. People went through it and they said, oh my God, is this intense? But don't make it any shorter. So we actually got a lot of buy-in, and I'll say that Kathy Blazer, who is my partner in crime, and Fumi Olopati, who became part of our team, we have now gotten over 15 years of time, and we're now at over 1,500 trainees, so they're in every state in the union in 27 countries. So we're trying to fill in that gap in the community setting, cross-training APPs, cross-training geneticists in oncology, cross-training oncologists in genetics. It's what you need, interdisciplinary training. So there's one way to try and get at this. Then there's this idea, again, of scaling complexity and risk. So if you're in a prostate cancer clinic, unfortunately, men don't care for families as much as women do. They do care, ultimately, but they're very focused on what's going on when they're in that clinic for metastatic prostate cancer. And so less than 40% end up getting tested, even though all metastatic prostate cancers meet NCCN guideline. So if you can use an approach where you can low intensity introduction, enough to get informed consent, and then spend your time counseling and putting that expertise in place when somebody has a pathogenic variant or a very complex family history that still needs explanation. And so the Magenta trial set out to test this and showed that there's basically an equivalence of a post-test counseling model. There are many details that we'd want to go into if we were really debating this, but the fact is that we're getting more and more acceptance of counseling light, I'll call it, but it's also appropriate for people who don't meet high-risk syndromic criteria. And so my perspective is, how do we build this into our system so we have the oncology clinicians who are well-located, cancer context insights and experience. We need to test essentially all cancer patients. We want people to practice at the top of their license. And we want Magenta trial demonstrated non-inferiority. We still need quality assurance. So we're talking all this talk about the EMR, all that. It's hugely important because how these things are tiled in, not in the media tab, but in the actual results section. So many people have gotten tested twice because the doctors didn't realize they'd been tested before, and they ended up carrying the cost for that because the insurance company remembered. All right. So what about population-based approach? Why are we waiting for people to get cancer to start the process? So I've already told you we miss 30% of patients who have a pathogenic variant based on family history criteria. And that's based on family structure. Do all of us have full families? Probably not. What about all the people who are adopted? What if your dad didn't have sisters? Not a chance you're going to see breast or ovarian cancer in that ship, and that's 2 generations already passed. So why wait? Prevention is so much better than cure, as it spares the burden of being ill. Now, there's a couple of exemplars, and I'll close with these last couple slides. Population genetic screening efficiently identifies carriers of autosomal dominant diseases. This is the Healthy Nevada Project. What do they test for? Lynch syndrome, HbOc, and hypercholesterolemia. We were talking about that earlier. Get at the chronic diseases that are important. Get beyond cancer. It's all in the same genome. So we got the same place to start. And what they show is it's a low rate. You might think 1.3 is low, but these are for people with Lynch syndrome, BRCA, and hypercholesterolemia, all things that we can change their mortality and their outcome based on that knowledge. So I think it's worthy of testing 10,000 patients to find the 1.5% or 2% that are high risk and need that stratified care. Same thing, population screening in Oregon, same concept, Geisinger's done it. There are a number of exemplars that are emerging showing us how to go about this. Now I have one that we did, actually this is cost effectiveness modeling done in England that showed that population-based screening for these breast cancer and ovarian cancer genes that are listed here was cost effective. It was less costly and much more effective than using family history-based criteria. So we have evidence for this advice. Now, this was a natural experiment. For a while, I was the VP of Medical Affairs at Natera for hereditary cancer. And while we were there was a surgeon in Houston who was willing to write the test orders for any woman attending one of 3 imaging centers. So no selection criteria at all. So you did not have to meet NCCN guideline to get tested. And people paid out of pocket $249 if they didn't meet a criteria that insurance paid. So here we are, 14 months and 1,900 women later. What did we find? To the right, you can see that the first one is check 2. That was the most common, and almost nobody met a guideline for testing. The next one over, most importantly, is PALB2 and BRCA2, that gray bar. Look at how many were discovered that met no guideline. Yet here they are, screening age women. Look at the median age as well. These women were in their 50s and 60s. Who gets mammography? Women in their 50s and 60s. And so I would take any of those PALB2 and BRCA2s, turn them around, send them straight back for MRI, and tee them up with a gynecologic oncologist who's going to talk about the pingrofluorectomy. So even though, here's a natural study, by the way, 30% of this population was Hispanic or Black, so it was a multi-ethnic population, and we weren't debating about access to care because they were all getting mammograms, so they were in there. We excluded people who had MRI and or previous gene testing, and curiously, I had to exclude 29 men. What were they doing there? Well, because they saw the flyer in the waiting room, and so they got testing themselves. No, I'm not kidding. I had to exclude 29 men. So I think the acceptance and voluntarism of wanting to know your risk is becoming more broad-based, but this, to me, was a very compelling rationale for population health risk stratification. So the next thing is, of course, well, what do you do with that risk? And that's the most important thing. I'm a replacement tonight, guys. You probably know that. Susan Domchek was supposed to be here. She would have done a much better job, I'm sure. But Susan wrote this paper with Dr. van der Heide, who happened to be her husband, also the Cancer Center director. But this is the concept of interception. And Fumi's talked about it. Michael's talking, we've all talked about it. And the idea that you have things that are already recognizable, polyps in the colon. You take out the polyp, you prevent the cancer. I don't know, Mike, what, 1 in 5 polyps, if untreated, become a cancer, right? I mean, somewhere in that neighborhood. So you just diminished, and we already know from Lynch syndrome that if you do the screening and you do the polypectomies, you have decreased colon risk, and nobody dies of colon cancer. Those were the early studies out of Finland that justified colonoscopy in broad populations. Nonetheless, this idea that we can identify that intermediate stage when the cells are still genetically less complex and more likely to be susceptible to lifestyle, to drugs that aren't toxic, and as a way of trying to prevent. So I'm excited for that concept. These are just a series of explanations. So Lynch syndrome I just mentioned. He already mentioned aspirin, polyps, and vaccines. Women with atypical ductal hyperplasia. We've known since the tamoxifen P1 trial, 89% risk reduction for women with atypical ductal hyperplasia. How do you get better than that? Okay, and that's for a drug that's $20 a month generic. Okay, that's tamoxifen. And we now know to use baby-tam, or lower dose, so that there's less objection to the side effects. Smoothened. These are for a disease called Gorlin syndrome. I actually trained with Dr. Gorlin at the University of Minnesota. I didn't know how famous he was when I took his course. But anyway, the point is this, they get thousands of basal cell cancers, and so drugs that were used in this class actually work in the hereditary syndrome. The same for the drugs for von Hippel-Lindau, because drugs that we use for kidney cancer can now be used for von Hippel-Lindau, and we're showing a reduction in new primary cancers. And the Olympia A trial, which was an adjuvant PARP inhibitors for BRCA carriers with breast cancer, well, we learned that the risk of new primary ovarian and breast cancers was decreased in those who got the olaparib. So we know that a PARP inhibitor might actually work for prevention. So there are new studies out there thinking about this. And then knowing the pathway, knowing the drug. This is from Judy Garber. She's the US lead of the BRCA-P study, which is using denosumab, which is, of course, a bone density drug, right? Well, it turns out it's in the Rankel pathway, which happens to link to BRCA1. And so they just closed the accrual, but this is a trial using a drug for bone density that is designed to decrease risk for BRCA1. So knowing the pathway, knowing the way to go is really a way to go. So by way of summary, patients with complex family histories, we need multi-gene panels to identify syndromes, other actionable PVs, and to assure coverage for what you see and what you don't see. I think whole exome genome sequencing platforms are likely to be the next generation technology, because there's no reason we shouldn't be looking at the whole thing. As they say, sequence once, read often. I think Bruce Korf might have had that quote. I don't remember who did it, but either way, the point is that once you have it, you go back as the evidence progresses. PRS holds a promise of further precision, and I think its earliest applications will be best for things like ATM and CHEK2, which we hate seeing in the clinic because they are moderate risk. We don't know how to do it. We want to know how to pick out the ones who are serious. And so I think this holds promise for that. Education and testing can increase the reach of our cancer prevention and interception. And then we need to be prepared to make a genomically literate workforce. And we were talking about EHR, so electronic health record. How do we get things to appear where they should appear so we can see them? I think that our understanding precancer biology, early detection, they put interception within reach. And I think that's exciting. So I'll close with this. It's my favorite slide. It says, I'd been here sooner if it hadn't been for early detection. So I'll stop and take any questions, and I'm sorry to keep you so late. I did my best Boston fast. Yeah.
Thank you.
Yeah.
Low-dose tamoxifen had similar effects as the 20 milligram daily tamoxifen.
It
How do
hasn't
you
been
feel on
tested against all of this, not the same size, but yeah, it's what we call it. It's kind of diminutive. We call it baby tam. I don't know why, but it's catchy. There's even a study called Baby Tears. There's a whole bunch of studies looking at that. There's one we just opened looking at low-dose tamoxifen plus minus omega-3, so we're trying to add the nutritional together with it. But you show that you can get less and less side effects. And so I think women, we're hoping that they'll take another look, because I think it's worthy. And it's already acceptable in our practices to start at a lower dose, to work our way into it. There's a study called the Renaissance study right now that is taking low-dose TAM in premenopausal women and then escalating until they get symptomatic. Sort of seeing where's that threshold, and to see if the secondary biomarkers like density are influenced by the lower dose, because that's going to be the toughest group, the premenopausal. Yeah. So I think it's the only problem, of course, one of the problems is the mortality benefit hasn't been demonstrated, even though I would think that a lot of this would follow naturally. So there's still gaps that we need to do, but we have multiple drugs in these pathways. Duave, so bezodoxifene with conjugated estrogen, actually moderates the symptoms and appears to decrease breast density, we believe will decrease cancer risk. So there's a lot of different ways to look at this, and Fumi was already alluding to the blockbuster drugs that help to manage menopausal symptoms, and then that opens up a whole world of what we can do differently.
Yeah, we use baby tam in our clinic.
Yeah.
Everybody gets it.
Yeah.
Yeah. They don't want to do it, but the early tamoxifen trial showed women 35 and over were eligible, and if they meet that eligibility criteria, we show them the data because it's compelling. For DCIS in our practice, we're using baby tam.
Okay, and it's the same for postmenopausal women as well?
Yeah,
Well, I guess, okay, no.
The Italian study.
Right.
Yeah. So if you look at, they've been in the study in the field now for more than 7 years, and the data is still hold up.
Yeah. Well, actually, the other thing about tamoxifen, too, is that you take it for 5 years, it's a lifetime benefit. The curves aren't going back together, which is what's been really interesting as we get longer and longer follow-up from those early studies, the curves stay separated in terms of that lifetime risk reduction. And I think it's a window of time that we're negating, as it were, or decreasing the burden of new mutational processes by maybe lowering cell proliferation, for example, and that just sort of does a reset before it starts to go up again. So I don't know, that's a simplistic way to look at it, almost certainly. But I think the pathway is the key.
I have a question. Thank you.
Yeah.
Wonderful talk. Thank you so much. If we are offering universal genetic testing, so anybody who wants to come and get tested, if we're not using a laboratory that offers PRS, do you think we are, not doing the right job?
Well, it's a good question. So the issue is is PRS so well developed that we're really at fault not to use it yet? I think we're at a juncture, Elias, where I think it's being abundantly clear. The paper just came out in, I think, Nature Precision Medicine on a coronary artery score, polygenic risk score. And again, showing a very good correlation, better correlation with outcomes than most other things that we currently use. So I think that it's on the cusp. And I do some consulting for some different firms, and they ask me, well, when's NCCN cover it? Well, NCCN didn't endorse multi-gene panel testing for 10 years after we were using it on a routine basis in clinical care. So I have no delusions that they're going to cover it anytime soon. And the real proof in the pudding is going to be not whether it's accurate. I think most of us are accepting it's accurate. Mark Robson often says, the test can be analytically correct, but clinically wrong. The question is about uptake, and can we compel people to act on this in a way that is risk appropriate? And it's nice that it's a linear scale. So depending upon your population, your resources for that population, you can scale what you do. Fumi and I both work in low resource settings. I wouldn't even, 19% of women in Mexico get mammography, okay? But if I highlighted the BRCA carriers and they got a doctor's exam, a mammogram, we'll downstage them from 3 to 2 or 1. And that's a huge impact alone. Oophorectomy, one of the cheapest interventions there are out there. Not even a hospital day, right? You're in and out same day. And all-cause mortality reduced breast cancer risk if it's done premenopausally, and give them all the progestin or estrogen that they want, as far as I'm concerned.
Yeah, I mean, I'm glad that you're doing the PRS because, we started talking about Black women in Chicago, and we went to Brazil. We went all over sub-Saharan Africa. We have a better polygenic risk model than everything that's been developed so far. But we're testing it in a research setting because we're committed to making sure everybody has a chance to survive cancer. And the obstacle we always get when you have too much is Americans are the last to adopt what everybody is putting in their health system. So if you go to NHS, all of the models that we use here were not developed by anyone in America.
No.
Because we do not share data. Everybody is afraid of losing their insurance. In the meantime, Canada, the whole world, even in Asia now, you can do polygenic risk score because people are trying to solve problems for their own populations. So the reason why he took, South America was because there's a very large migration. There are Mexican, founder mutations that you will find among people of Mexican ancestry in America. They may look white, they may look black. That's not what is going on. It's what's the genetic ancestry. So that's really where all of this work is going. And I'm glad that you have an institute and you continue to study it in your own health system.
Thank you very much.
And thank all of you for staying to this bitter end. I mean, thanks very much.
Yeah, I just want to thank our wonderful and esteemed speakers. Thank you for coming here all the way, coming from London, from Philadelphia. Really, I think the take-home message is that prevention matters. I think every cancer center must include prevention strategies, and I think this is just the way to go. So I would say with this, thank you, everyone, and let's begin. Thank you.